এক থেকে পুরো একদম না, সিরিয়াল ওয়াইজ দেবে। আটটা তাই তো? সাতটা? কার কাছে হাতে থাকবে? কার কাছে? নটা আমার রেডি আছে, নটা। বিকেলে এক দু এই যে। এই দেখো আমি বলে দিচ্ছি কি এখন দিবে। এই এক দুই তিন চার এসএলবি দিলে, তারপরে হচ্ছে অ্যাপনি একটা দেখছি, তারপরে যাবে শিওর, এই যে তারপরে যাবে শিওর, এটা এই দুটো তো, তারপর শিওর শিওর শিওর, শিওরের মাইক এইটা। তার কটা হলো? তিন সাতটা। সাতটা এই দুটোতে যাবে, দুটো হয়ে যাবে, ওটা কি দিতে যাবে? তাহলে ওই দুটো দিয়ে দাও। ঠিক আছে এই দুটো দিয়ে দাও, তাহলে ওই একটা কি যাবে না, ঠিক আছে ঠিক আছে। এবার এই দুটো তো মনে হয় কোনটা হবে? পরপর লাইন ওয়াইজ সাজাবে কিন্তু। ভালো প্রোগ্রাম হয়েছে, একটু জেনারেটরওয়ালা আমাকে ঢোকার সাথে সাথে বলতে হবে রাত্রি দুটো আড়াইটে শেষ করেছে প্রোগ্রাম। ডাক্তাররা বলছে মিউজিশিয়ানরা নেমে গেছে 11টার সময়, হামলোক টিকিটে কম হয়ে ওরা উঠে গেছে, গান করছে নাচছে। এ কোনটা বলছো দাও? কার্ডটা ব্যাটারির জন্য রাখছে। আমার কাছে নেই। কি ওইখানে আটটা দেবে, আটটা। দুটো।
দিয়ে আমার কার্ডে তুলে নিতে পারবে কিংবা আমার কার্ডে কপি করে দিতে পারবে।
দেখে আসবে, হ্যাঁ ব্রেকফাস্টে দিয়েছে।
হ্যাঁ দেখেছি তো,
ঠিক আছে।
ডিম আছে, ওইদিকে ওই মাসালা টোকা বানাচ্ছে,
জ্যাম
আর
পাউডার
সেই
ওইদিকে
একই।
আছে আর
আর
ওদিকে
জ্যাম
না আজকে
পাউডার।
ওই আছে কি বলে
চিকে বললাম।
পিৎজা টাইপের, পিৎজা তো নয় ওটা কি বলে ওই
দিয়ে একবারে ছবি তুলে খেয়ে চলে আসবে।
চিল্লা চিল্লা।
চ খেয়ে আসবে। কোথায়? লাগবে না, এমনি দিয়ে খেয়ে আসবে। দেখে দেখে খেয়ে ওই কোনো না দিয়ে খেয়ে আসবে। দেখেন ম্যাম থাকে চেষ্টা করতে খেয়ে মনে ভালো। এ তোমার পায়ে আরাম সরে যাচ্ছে কেন? পায়ে সরে গেল ফট করে। পায়ের খুব কাজে যাবে না লাস্টে, পায়ে ধরে যাচ্ছে। হ্যাঁ, যাকে দিতে পারো তাকে তো দিতে হবে। আশেপাশে দেখবি তারা দেখছি তো এই যাচ্ছি।
ফোন করো বাঁধাকপি ফোন করলে বলে দেবে। মাকে ফোন করো বাঁধাকপিকে ফোন করলে বলে দেবে। আজই
ব্যাংকে রেখেছিস? এ মোটামুটি হ্যালো।
Morning. A very warm welcome to all. Today is the last day of our conference, and hopefully, after the grand party yesterday, everyone is energized. How was the party yesterday? All attended? Good? Thank you, sir. So, the first, we'll have a speaker on ethics. And I'd like to invite Dr. Madhuri Chatterjee, Associated Professor from Sanaka Hospital, Sanaka Medical College and Hospital. Ma'am, please come on the stage. And I'd like to invite Dr. Rupa Goswami and Dr. B.B. Karunamai to chair this session.
So good morning all. Today I'll be just walking you through the slides that is about good clinical practice. So one must be thinking why good clinical practice, we all are doing good clinical practice, right? So what is so new about this? But this actually is something to do with not individual care or individual patients. There are several stakeholders in any research. So we are talking about all these and how to defend the rights of the participants, especially biomedical research involving human participants. So what is good clinical practice? It is a set of standards, that is ethical and scientific quality standards. So one has to actually follow all these guidelines, or these have been set by certain councils, and for any research these are mandatory. So and it entails not only conduct of the research, even designing of the research and how to report it, how to publish it. So all these are incorporated in this good clinical practice. So this photograph, if you see, in the first one, there's a doctor who is actually doing an experiment on though at that time they were called Negroes, the black Americans. And it was a experiment on syphilis. And this continued for 40 years. And this person, he was a whistleblower, he was a public health specialist, Dr. Peter Buxton, and he was the whistleblower who said that at that time the syphilis treatment was already there. The penicillins were already there in the market, but these participants rather, they were infected with syphilis, but they were not given any treatment. So finally it led to a trial, and in which we see this Bill Clinton had to render an apology. So this was some of the notorious things that were done. So the history, so it's gradually developed. It was not that in one day we got all the history. So Nuremberg Code, why did it come up? Because of the Nazi experiments pre-war, pre-World War II. The Nazi experiments were done on the German, they had done these experiments, and this trial was done by the US, and these doctors, they were, obviously the trial had put them, and there was a certain codes that came out of this trial. That is called the Nuremberg Code. Then we have the Skefevor amendments. Why these amendments? Because we know the thalidomide tragedy, which was in Europe, it caused havoc, but there was a doctor in US, the FDA doctor, Dr. Kelsey, he did not allow this drug to enter the US. So the industry or the pharmaceutical industry has to prove that a drug has to be safe before it is even marketed or put into trial. Then all these led to the Declaration of Helsinki, and obviously the Belmont report was taken into consideration, that is the Tuskegee syphilis trial, and we have these Universal Declaration of Bioethics and Human Rights. So this is the timeline of the, so obviously we have this oath of Hippocrates which we all follow as doctors, but then all these developed to help us in the clinical research. So this Declaration of Helsinki was developed by the World Health Council, and then these the International Council of Harmonization, that was then it came into practice. They developed these good clinical practice guidelines. So this is about the history. And obviously it was with due consideration with all countries, say USA, Japan, Canada, Australia. So all these countries, they gave their inputs and this came into practice. Now, what about our India? At the national levels, obviously we had Charaka Sanhita, where we have all these certain rules and regulations which we follow as doctors. But the first policy by the ICMR was given in 1980, and it has been revised. Latest revision was in 2017, but then again what happened was in 2019 there was a new Drugs Clinical Trial Rules Act, where we have to register all clinical trials in the portal of ICMR. And in 2017 it also incorporated the medical device rules. So what is clinical research? So clinical research does not only mean developing new drugs, it is also validating methods to prevent illnesses. So that is also research involving human participants. Then we have investigation of the causes of illness. Why was this disease, why did this disease happen? And then we have epidemiology of clinical conditions if we want to know, and obviously the therapeutic measures or any other new diagnostic measures. Now, what is academic clinical trial? We all participate in these, are actually stakeholders in these academic clinical trials. So this definition is a clinical trial intended for academic purposes. So the drug is already in the market, or the treatment or the modality is already there in the market, but perhaps we are testing a new route of administration or a new dosage form or a new dose. All these come under the academic clinical trial. So clinical research actually incorporates, if the good clinical science, obviously one has to know, have the knowledge of science to develop or design a clinical trial, and that will lead to a good study design. Then the conduct, how we are conducting the trial while we are proceeding with the trial, that also needs some ethical conduct, and all these will lead to integrity and quality. Why are we so because when we have to divulge the results, unless and until it has been conducted in an ethical way, we won't get good results, the results that can be validated. And why are we so nowadays we also have these broader fields of research, that is stem cell research, assisted reproduction, and also these prenatal diagnostic research. These all are invasive and they are involving human participants, and also in certain cases the unborn child. And now the latest is the artificial intelligence that has been incorporated into clinical research. So what are the principles of ethics? A, B, C, D, E. So what is A? That is autonomy. This is the basic principle. B is beneficence. C is privacy and confidentiality. D is non-maleficence or do no harm. And this justice is also called equity and fairness. So we mainly deal with distributive justice during clinical research. So the first and foremost is, although we say that the clinical research is done for the society, but we have to see whether the risks, whether the benefits outweigh the risks. only then we can subject the human participants to any to any study. So, this is the first and foremost, and there are certain general principles that it is essential. Obviously, to develop our field, we have to do research, because there are so many things that are happening, that are being, newer fields are being developed. Newer treatment, newer modalities, so all these, so it is essential to do the research. And it has to be voluntary. So the participants have to volunteer. It's not that we can coerce them. And obviously non-exploitation, that we should not be, the vulnerable groups should not be forced into the study. Or we should not, because we want to do a study for certain community and a vulnerable group is taken for that study, just because we want to safeguard that community, we should not be doing it. And obviously there is principle of social responsibility, but we have to ensure the confidentiality and privacy of the subjects. And whenever we are doing a study, we have to see whether the risks are minimized. Minimal risk to the subjects. So if it entails very high risk, we should forego the results unless and until it really there is a wider benefit or a broader benefit in the long run. Obviously, one has to prove that their competence and benefit should be maximum. So all these are the essential general principles. Now, coming to the Institutional Ethics Committee. For all research, we have an Institutional Review Board and an Institutional Ethics Committee. So the members may be the same or maybe a little different. The function of why do we need this Institutional Ethics Committee? It is to safeguard the rights and benefits of these participants, the human participants. And obviously, it will oversee the ethical aspects of the trial, from the perception of this design to the conduct to the publishing of the results. And obviously, they will compliance, whether the researchers are complying with the protocol, they have to oversee, and they can also give their inputs and interfere if they see that there is something wrong that is being done. So composition of IEC, that is the Institutional Ethics Committee, it is diverse. So different age and different, it has to be like a amalgamation of age and gender should be maximum. And minimum for a quorum decision taken, it has to be 5 members, but the members can be more than from 7 to 15. And there should be 1 person whose primary area is not medical science. And 1 member who is independent of this institution has to be from a different institute. So, and all these lists has to be maintained by the Institutional Ethics Committee. So usually we have chairperson, medical experts, legal experts, social scientists, and theologist, obviously, and layperson, because they can decide about what is actually wrong or right in the society, and obviously 1 from the industry. And nowadays with this artificial intelligence, it is mandatory that a computer engineer or a data scientist are also incorporated, and also the Institutional Ethics Committee has to train their members in artificial intelligence or say computers. So who is the principal investigator? The researcher who is conducting the research is the principal investigator, but who can be the principal investigator? So in a multicentric trial, there can be a team of principal investigators, but each of these investigators, or one person is a principal investigator, and he or she delegates different team members in different centers. And if the principal investigator is not a physician, then a qualified physician or a dentist should be a secondary sub-investigator. Now, what are the responsibilities of this principal investigator? So, the qualified physician has to submit the documents about the qualification. They should be able to give immediate medical care if any, and also they have to take decisions on behalf of the participants. So, who is the investigator? Obviously, there are certain regulatory regulations about who can be the investigator. So, these are by education or qualification or even experience. So, these have to be put into place. So, these are they can be the principal investigator, and they should also command that they can delegate responsibilities to other people in the study. So, they have to command this respect, and obviously they have to submit their curriculum vitae, and it has to be, they should communicate with the institutional ethics committee. So, beginning with the protocol about the investigational brochure, what is being incorporated in that investigational drug brochure, or if there are any changes that is happening during the trial, they have to communicate with the institutional ethics committee. And what is this? The informed consent document, ICD. They have to deliver this informed consent document after it is approved by the institutional ethics committee. So, what is protocol? Protocol is a study, is the scientific document that is given, in which we inform the IEC about why the study is being undertaken, what are the outcomes that we want to achieve, and who will be the participants, etc. So, all these will be, and what is the time limit in which we will conduct the study. So, all these have to be incorporated into in the protocol. So, the study has to be done in compliance with the protocol. We cannot change the protocol unless and until there are some immediate changes that have to be made, but again these have to be informed to the IEC, and they have to approve of these changes again. And the IEC will give favorable opinion, and also the sponsors have to be given this protocol before the initiation of the study. The randomization. So, when we do either a placebo controlled study or any studies where we are doing it, there are randomization which also has to be given in the protocol, and we have to follow that. It's not just random. The day I start the study, I start doing a randomization. It has to be incorporated in the protocol itself. And obviously, the first and foremost is autonomy, basic to human rights. So, obviously, the participants have you have to inform the participants about why we are conducting the study in their own language, what will be the benefit or what will be the risks, they have to be informed. And till when the study will be conducted, what are the risks? The risks have to be informed, and only then if they volunteer, they have to be subjected to this, and they also have to be given the information that they can withdraw from the study without any effect on their treatment. So, all these voluntariness have to be, then we should, and if we are subjecting vulnerable groups, then there are some other agreements that have to be made, and vulnerable groups, not only it entails that a community leader can come for these vulnerable groups, but even if a community leader comes, individual participants also have to be informed about the study. So, what is this informed consent documentation? It has a patient information sheet, and obviously once they have understood, there is it has to be signed by the participant. So, principal investigator discusses all these risks, etc., when they are giving this informed consent, and they have to be given time to ask questions. If so one has to take time. It's not that the day I want to start the study, I give and I say, just sign it. If they want more time, you may have to say that, okay, you come at a later date and then please discuss, and whatever are your queries, we will try to answer. So the principal investigator has to answer the queries and then let the participant sign. And it has to be dated then and there. One cannot say that, okay, I'll take the signature and the date I'll put in the later on. It cannot be, it has to be submitted after the date has been given. Now, informed consent has to be given by the participant, or if the participant is mentally unstable or is not, then a legally acceptable representative has to be there who will represent this participant. If no one is there, then an impartial witness has to be there when the document is signed. Now, a child between the age of 12 to 18 years, for them, and from the age of 7 to 17 years, they have to sign an assent form. Even if the parent is giving a consent, this assent form has to be there for a child of 7 to 17 years, wherever there are any intervention or risks that are imposed. Principle of beneficence, so obviously we will do whatever is in our care will be of benefit to the participant. So the risk-benefit ratio has to be weighed, and if the benefit is more, only then we should proceed with the study. And it applies to all individuals, whether the vulnerable groups, whether the participants, whether they come from any part of society, they all have the same rights. Now, principle of non-maleficence. What does it mean? Do no harm. So, if we cannot give any benefit, do no harm. So, that is, whenever our study, we should not impose any any investigations which may be harmful for the participant, so, or any tests that may not add to the results, but it may be more harmful. So, that is principle of non-maleficence, and we have to give proper standards of care if any harm has been done. Privacy and confidentiality. So, it is the records have to be protected, and even the participants have to be whatever information they have given, it has to be protected for a period of time, and also it has to be, what is this privacy? It is not what I prefer. It is the privacy or confidentiality, the eyes of the participant, not in the eyes of me. I feel that it is okay, I can divulge this information, but no, it has been given as a trust to me by the participant. So, we have to inform them before we divulge. Obviously, there are certain reasons when we have to divulge, especially in the court of law, etc. But for otherwise, we are not supposed to. And principle of justice, obviously, there are several types of justice. It is mainly distributive justice. So, it is not equality, rather it is equity, where all the equity recognizes that every person in different circumstance may have to be given opportunities to come to the same level. So, if you see in this picture, this person is, a short person is not able to see the match. But here, all of them, so you have given them opportunity so that everybody can observe the match. So, this is something that we have to do in any clinical research or a trial. Now, what happens to the clinical trial data? Once the data has been collected, what do we do with it? So, we have to handle them properly, we have to save them, because nowadays we have electronic methods by which we can save them and store them, and obviously then we have to validate and interpret it. So what is important about this? We follow a mnemonic called allocac. What is allocac? That is attributable. The data has to be attributable. It's not that I fabricate the data or the clinical researcher fabricates the data or falsifies data. It has to be attributable to the research. It has to be legible. Nowadays with electronic, it's the same, like legibility doesn't matter much. It has to be original. We cannot, as I said, that it cannot be fabricated. Contemporaneous means then and there. It has to, at that time when we are recording the data, it has to be dated. It has to be accurate and complete. So that is called allocac. So if we follow this, then our data may be valid. Then we have to prepare the final report, and upon completion of the trial, not before that. But anything that has, suppose there are any problems during the study, or there are adverse events or adverse reactions, we have to inform the Institutional Ethics Committee about within 24 hours, and if we find the results of these adverse events related to the research, we have to we have to submit the report within 14 days of occurrence of this. Then come to publishing. So whenever we are doing any scientific research, we have to disseminate this information, and this information can be disseminated by publishing. But again, this publishing, there are several checks for preventing this plagiarism, and this is the process of practice of using another person's ideas or work is called plagiarism. So how to deal with plagiarism? There are several software tools that can be taken into consideration. So this is, now what are the ethical principles that are specific to artificial intelligence? The algorithms that has been developed, it has to be transparent. It should not be a black box. So it should be, one can evaluate it. It has to be fair and non-discriminatory, because there can be many small research units where artificial intelligence may not be able to. So if we send participants only in those centers, there can be discrimination. Now coming to this autonomy or human in loop, that is all the decisions taken by the artificial intelligence. So there should be a person who will take important decisions. It should not be that the machine gave us this information. So the researcher has to be there to take important decisions if one sees that it is discriminatory or there are some problems with the decision-making capacity of this artificial intelligence. Accountability. Now, accountability of this artificial intelligence, whether it lies with the developer or with the user. So that has to be, before we start using it, it has to be demarcated. And also, the data governance has to be very rigorous. The Institutional Ethics Committee has to include data scientists or experts in computer engineering. And obviously, there should be transparency in reporting. The algorithms may change, may have to be this, one has to divulge what was difficult in these algorithms so that future researchers may develop it in a better way. So these are mainly the GCP principles, that is, one has to conduct the research with ethics and consent, informed consent with information, that is knowledge to the participant, and follow the science and protocol. So these are so what is research? The Nobel laureate has said that research is to see what everybody else has seen, but nobody else has thought about this, right? So these are my references, and thank you. So any questions?
Thank you, madam, for very nice reminder to all of us regarding our responsibilities towards the humankind in dealing with in day-to-day practice. So, if there is any queries, the madam would love to
Yes,
clear
ma'am.
it, I think.
Looking for a mic. Beautiful lecture.
Thank you.
Lovely revision of all the points, and the one on AI is something new. So, AI could be used as a tool in our research as well. So, it's time that we have a member
Yes, yes.
now on?
Yes.
Okay.
Because the ICMR 2023 guidelines has mandated this.
Okay, okay.
So-
And they need to be participating in all the ethics committee meeting.
Yeah,
then?
yeah. No, not in all. Wherever we are using these AI tools, there they have to be there.
Okay, okay. So there. So it is like optional.
Yeah, it's optional. But again, like they are saying that all the members of the Institutional Ethics Committee have to be trained in these computers and AI science.
That's it. Because even DNB is, NB is conducting
Yeah.
courses repeatedly. So, okay. So even for using any AI tool, do you have to disclose that in the research paper
Yes,
when you're
yes,
doing?
yes, yes. Even
Because everybody is using it.
yeah,
But
so they have to disclose it when they are publishing it.
Publish
It is
it.
mandatory now.
okay, okay. Thank you.
Thank you, madam, for a nice presentation. For the information of the house, I just want to inform you, how many of you have done a course in BCBR? 1, 2, 3, 4, 5, 6, 7, 8. So this is called as the basic course in biomedical research. This is available in the SWAYAM portal. You can do it online, and it is mandatory, specifically those persons who want to go into medical college and pursue your future, specifically the candidates who are there doing their post graduation. It is always mandatory that you do it, so that it is mandatory now for you to become a faculty in any of the medical colleges. It's easy, there is nothing difficult to do it. There are 30 modules which are there, which you just have to go through it online in the cell phone, and then after you complete the course, you appear for an online examination and appear for the examination and get to secure minimum 50 points. Examination is offline, but it is offline, but it is done online. Examination is done online, but you have to be there in person. You have to be there in a person. 100 questions should be there, and you have to secure minimum 50 marks. It's easy, and you will get, madam, whatever information madam has also given today. You get all the information there also, and everyone must do it. That is a mandatory thing now.
Thank you, madam. Thank you for your nice talk.
Madam, please. I'd like to thank Dr. Mukherjee for giving us an excellent overview of clinical research and ethics in clinical research, and Dr. Sarangi sir to making us aware of the fact that we need to do a basic courses. Next time in Aismoc, I'll feel that everyone who is presenting paper should have done that course so that their papers are ethically designed. Thank you. Now I request Dr. Karuna Mese and Dr. Rupak to facilitate. Now I'll call on Dr. Rajranjan Kumar sir to felicitate our Dr. Karunamai and Dr. Rupak. Okay. Now the showstopper of the day. We all are waiting breathlessly for the mediquiz. And I'll request all the mediquiz of the stage. And I'll request our quiz master, Dr. Somerupa and Dr. Deepak, to be on stage. Dr. Somerupa, Dr. Deepak. You have come from front.
सब मजा लेने
Come from. Yeah. No, all can come through this side. No back door indeed. Come from front. इधर से आइए सर.
Hello everybody. We'll just take 10 minutes for starting the quiz to set up the stage.
উপায়ন একটু হোল্ড Sir, Enam, RI.
হ্যাঁ চলে এসছে আরে তুই তো স্কোরারে ছিলিস রে আচ্ছা আমি পাঠিয়ে দিই
All the participants, please come up on stage.
Hello. 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 Hello.
देखिए हाँ
Hello.
हेलो 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 हेलो
We'll test the buzzers first from Team ISP. Press any number from 1 to... Your name is displayed? Yes. Next is Team Tata. Working fine. Next is Team Raurkela. Fine. This is Team DSP.
हेलो
Okay, all do it simultaneously once. On the count of
Hello.
3. 1, 2, 3, go. Who has pressed the buzzer? Team Raurkela. Any questions regarding this? Any doubts? Any queries?
You want to try it again?
Again, sir. Fastest finger.
Satisfied?
Once more.
Fastest finger once more. On the count on the count of 3. 1, 2, 3. Clear the queue, please. Okay. On the count of 3. 1, 2, 3. Go. Who is pressed? BSP. Okay. So, huh? नहीं sir, वो milliseconds का difference आ रहा है. Okay, so everybody cool with it?
Yes, yes.
So shall we start?
Yes, ma'am.
Good morning, respected dignitaries, esteemed faculty, dear delegates, and the brave souls who have agreed to face this Mediquiz on the last day of the conference. I am Dr. Soumya Rupa Maji, and my colleague is Dr. Deepak Singh. We will be your quiz masters for today. We are joined by Dr. Ajit Karmakar. He will be our moderator for this quiz. And Dr. S.S. Patil sir will be the scorekeeper. After 2 intense days of continuous medical education, we have finally arrived at the most refreshing session of the conference, the medical quiz, the only session where falling asleep is not an option because somebody might just ask you a question. Medicine is a serious profession, but today reminds us that learning medicine does not always have to be serious. This quiz is not just about what you studied the night before exams or what you last Googled during duty hours. It is about presence of mind, teamwork, and occasionally guessing with great confidence because in medicine we call it clinical acumen. To our participants, you are already winners. It takes immense courage to sit on this stage and risk public exposure of knowledge gaps, something we usually reserve for ward rounds and Viva exams. To our audience, your claps, cheers, and sympathetic smiles will be deeply appreciated. So let this quiz be the perfect finale. Fun, fast, So let this quiz be the perfect finale. Fun, fast, and hopefully not requiring any resuscitation. I assure you, the questions are challenging, the rules are fair, and no one will be asked questions from chapters marked by seniors as not important. So relax, enjoy, and let your neurons fire faster than the caffeine in the OPD. All the very best to the teams. May the smartest brain win. We have 7 teams among us. Introduction will be given by my colleague, Dr. Deepak.
Thank you, Dr. Shomarupa. A very good morning to all the delegates present and to all participants. I am Dr. Deepak Singh, today's co-host for this medical quiz. This session is all about sharp minds, quick recall, and sound clinical reasoning. So let us first meet all the participants who are ready to take on the challenge. So I will ask all the participants one by one to introduce themselves and their plants from which they are. I will start from ISP.
Hi, good morning everyone. This is Dr. Rohit Roy Chaudhary from SAIL ISP.
Good morning everyone. Dr. Jitendra Pandey from SAIL ISP.
Good morning everyone. Dr. Kota Vijay from Tata Steel.
Good morning everyone. Dr. Tarannum Shah from TMS Jamshedpur.
Good morning everyone. Dr. PJ Roy from IGH RSP.
Good morning everyone. I am Dr. C.K. Kasi from RSP Rourkela.
Good morning everyone. I am Dr. Dheeraj from Bilai Steel Plant.
Good morning everyone. I am Dr. Shaunak Ghosh from Bilai Steel Plant.
Good morning everyone. I am Dr. Manish Kumar from DSP.
Dr. Soikat Mahato, DSP.
Good morning, I am Dr. Sri Nagesh from Vishaka Steel General Hospital, RINL.
Good morning, Dr. Rakesh Chandra Maheshwari from RINL.
Good morning everyone, it's Dr. Santosh Chaubey from BSL.
Very cool and warm morning to everyone at the same time. Dr. Mohit from Bokaro.
Let us have a big round of applause for all the participants, please. I will be now giving a brief overview of all the rounds that we will be having today. There will be 5 rounds: Pandora's box, vitals and vibes, picture perfect, tachycardia, and budge fast, triggered later. The first round will be the direct question. Vitals and vibes are clinical scenario-based MCQ questions. Picture perfect is an image-based challenge, which will be the other round. Tachycardia will be a rapid-fire round. And lastly, the final round is also a buzzer round. Detailed instructions of each round will be provided before beginning of every round. So teams be prepared and audience stay alert, and let us begin our today's quiz session.
Pardon? Audience questions will also be there.
We will be having audience questions after first 3 rounds.
Yes. And we have prizes for the same.
Our first round is Pandora's box. This round has direct score questions. There will be 2 questions per team, and in this round, the correct answer will earn you 10 points. And if you cannot answer, then the question will pass to our next team. Then that answer will earn you 5 points. The rounds will start from TMT Bokaro, clockwise, then anti-clockwise. there will be no negative marking. And the highlight of this round is the participants will get the opportunity to select their own questions. You will have to select the number, then we will press the number and the questions will appear. So all the instructions are clear to you. So we can start the first round. We are starting from Bokaro.
Hello. I was born on 5th. So question number 5.
Sir, your question is, which is the first medical college established in Asia? Your time starts now.
Is there any options?
No.
No.
No, this is not a buzzer round. Like this, then it will come back. 30 seconds, it's almost over.
Patna Medical College.
That is a wrong answer. Team Visakhapatnam, will you try?
Madras Medical College?
First medical college established in Asia.
Madras Medical College?
No, sir. Team Durgapur.
Okay, pass to the next team.
Calcutta Medical College.
This is the right answer. 5 marks to Team Bhilai. Team BSP. Calcutta Medical College.
It was medical college. Medical college.
Oh, welcome, sir.
Sir, then question is wrong, sir. Then question is...
The Medical College, Bengal.
Question is valid. Question is invalid. The question is valid, answer is invalid.
Nobody could. Because he will not be the question is valid.
So, Team Visakhapatnam, please select your question.
9.
Sir, your question is, CRISPR-Cas9 technology is approved by FDA for which disease? There is no negative marking, you can guess, sir. Your time is over.
Sir, lysosome storage here.
No, sir, that is wrong answer. Team Durgapur, will you try?
It is used for gene therapy.
What?
Gene therapy.
Which disease?
For which disease? Particular disease?
Okay, Team Bhilai.
It was a tuberculosis.
No, wrong answer. Team Raurkela.
Hemoglobinopathies. Sickle cell.
Yes, that is right answer. 5 points for Team Raurkela. In 2023, Casgevy, a cell-based gene therapy approved for treatment of sickle cell disease for patients of 12 years or age and older with recurrent vaso-occlusive crisis. Team Durgapur, please select your question.
Question 7.
Your question is, people of this blood group are predisposed to diarrhea due to Vibrio cholerae, Shigella and E. coli. What is the blood group? Your time starts now.
O positive.
O positive is right answer.
Team Durgapur, 10 points.
Team Durgapur is will be given 10 points. Team Bhilai, please select your question.
Number 2.
Which ethical consent allows treatment without consent in life-threatening emergencies?
Implied consent.
Implied consent is correct answer. Team Raurkela, please.
1.
Name the proton pump inhibitor with meal-independent acid suppression property.
Pantoprazole?
No, that is wrong answer. Team Tata, will you try?
Vonoprazole?
No, that is also wrong answer.
Esomeprazole?
No, sir, that is also wrong answer. Team Bokaro? No, sir.
Sir, Vonoprazole.
No, sir. Team Durgapur?
Omeprazole?
No. Team Bhilai? Okay, Team Raurkela? Your question. So, anyone from the audience, will you try to answer?
Yes, that is correct.
Dexlansoprazole is correct answer. So, Shomomurupa, please give the gift to madam.
We have a small token for you.
She is from RSP, you can add the points.
No. 1 pen for RSP.
Next.
Team Tata, please select your question.
6.
Who introduced bedside teaching to modern medicine? After 30 seconds.
William Osler?
What?
Osler, William Osler.
That is right answer. Team ISP, please select your question. What is delta bilirubin?
No.
Team Bokaro? Team Visakhapatnam.
In case of porphyria, the breakdown, hemoglobin breakdown.
No. Team Bhilai.
Delta bilirubin, which is bonded to albumin and takes time to degrade.
Yes, that is the right answer. For the next set of question, I will ask Dr. Somarupa.
Certificates for credit hours, as our CM is over, certificates for credit points are available at the registration. One can go one by one and collect it for them. Okay, thank you.
Okay, so now we'll start from Team ISP. Please select your question. 19. DALI, Disability Adjusted Life Year, is the sum of, your time starts now.
Years years lost to treatment. Some of the rest days, matlab, not able to work actually. Days not able to work. Actually.
No, it is the sum of two things. So 2 or 3 things, whatever. Okay. So next, BSL.
Some of.
Sorry. I'm sorry. Next is Tata.
Duration of illness plus time to recover. Return to work.
No, ma'am. Next is RSP.
Total duration of hospitalization plus the duration of out hospital care.
No. BSP. Durgapur.
Life expectancy minus disease-induced loss of age.
No. VSP, Visakhapatnam.
Total active life minus the time spent in hospitalization.
No, sum of. Team BSL.
Sum of loss of work hour.
No. Anybody from the audience? Yes, you there, sir. Yes, correct. Due to it's almost correct, yes. Years of life lost due to premature mortality, actually. And with the years lost due to disability. So, actually nobody.
We told actually.
Yes, but if you had to tell the sum actually. Okay.
No issue.
Okay. So the next, Team Tata, select your question please.
10.
10. Let's see what is in store for you. What is the first approved mRNA vaccine? There's no negative, you can just attempt.
Smallpox vaccine.
COVID vaccine. It is the COVID vaccine.
If they chase their answer before anyone else has attempted it, I think they should be allowed.
No, ma'am, but the quiz master had said no. Means response has been committed.
Okay, quiz master's decision.
Quiz master has answered no. Then it was the
Okay, we have extra questions. Let's do another question.
single attempt because sir, we said
Okay,
Patna,
then
we are saying Calcutta.
We'll give another question. ठीक है?
Okay, let us complete the teams. After that, we'll go to Tata. We'll give. Yes, I have scrapped the question. That is fine. Okay, please select your question. Which diagnostic method detects circulating tumor DNA in blood?
The tumor markers?
No, ma'am. Team RSP?
Fish.
No. BSP?
Northern blotting test. Northern blotting test.
No. Team DSP?
Flow cytometry.
No. VSP? The name of the method, the broad method under which everything can come. VSP? Okay, Team Bokaro?
RT-PCR.
No, sir. ISP?
CBNet?
No, sir. Anybody from the audience? I need the method actually. No. Who said liquid biopsy? You, sir. That is the correct answer. A big round of applause.
वो लेके RT-PCR में ही डालेगा तभी DNA डिटेक्ट होगा।
17.
Team RSP, 17. Among the anti-diabetics, which one has a uricosuric effect?
Dapagliflozin.
Who said the answer? Yes. Okay. Yes, the correct answer. 10 points to Team RSP. SGLT2 inhibitors, actually. I'll give you that. Next is Team BSP.
Question 18.
18. Who is the first Indian woman to obtain a medical degree?
Passed.
Okay, so Team DSP?
Ananda Jaswi.
Team VSP?
Pass, pass.
मैम कादम्बिनी गांगुली और आनंदीबाई जोशी मतलब आनंदीबाई जोशी तो है ही लेकिन वो डिग्री शायद कंप्लीट नहीं कर पाई थी कादम्बिनी गांगुली
Right answer. Actually, it is Anandibai Gopal Rao Joshi, but Kadambini Ganguly was the first to practice medicine. Dr. Anandibai Gopal Rao Joshi could not continue practicing her medicine. 5 points to team ISP. Next is team DSP.
13.
Who pioneered the use of oral rehydration salts therapy? Okay, time up. Team Vishakhapatnam.
From Bengal, some Chatterjee.
Team BSL. Full name? Yes, I'll give you that. Dr. Dilip Mahalanabish.
Dilip Mahalanabish.
Yes. 5 points to team BSL. Next is team Vishakhapatnam.
11.
11 is over actually. 11 is already done. So you have to choose from the red ones.
8.
What is Gallavardin effect?
Phenylation effect, and when we press it, bradycardia is there.
With the mic, on the mic please.
Near aneurysm, if you press, there is bradycardia.
No, sir. Team BSL?
In severe AR, the murmur is held all over the precordium. It's a Gallavardin phenomenon.
No, sir. Team ISP? No. Team Tata? Team RSP? Team BSP? Team Durgapur? Okay. So anybody from the audience? Yes, ma'am. Yes, yes, ma'am. That is the correct answer. Yes. Team BSL, please select your question.
Question 3.
What is the most sensitive indicator of health status of a community?
Infant mortality rate.
Correct. 10 marks to Team BSL. Okay. So that brings us to the end of round 1. The scores, please.
Team BSP has 20 points. Team Bokaro has 15 points. Team Rourkela also have 15 points. Team Durgapur has 10 points. Team Tata has 10 points. Team ISP has 5 points. And Team Visakhapatnam is yet to score a point. So, now I invite Dr. Shomurupa to commence round 2.
Okay, so now we come to round 2, or as we would love to call it, vitals and vibes. It is basically a clinical MCQ round. You will be given a short history along with 4 options. The timer will start running after the options are displayed. Okay? And we have 2 test questions to get you acclimatized to the round. Correct answer will give you 10 points. Wrong answer, this round has negative marking. So it will be -5. Please select the answers carefully so. 2 questions will be given to each team. There's no passing and total of 14 questions. Okay? So we have 2 test questions, not related to medicine. Who was the first Indian to win an Oscar award? This is not a buzzer round. This is not a buzzer round. Nobody. This is a test round.
Test round. Test round.
Yes, Dr. Bhanu Athaiya, it is. Okay, so your correct answer, it comes green. This is a test question to get you acclimatized to the round. For the film Gandhi. Till which year was Calcutta the capital city of India? Your options are? Anybody, can the audience also attempt? I cannot give anybody if you tell all together. 1911. Yes, sir, it is. Because you answered a question. Okay, so this is not a buzzer round. After the options are displayed, the 30 seconds timer will start running. Clear?
Round will start with?
Round will start with?
Which?
You.
You.
Yes, we'll allow only one answer. Please decide amongst yourself. We do not want any other disagreements.
30 seconds, no, ma'am?
30 seconds. And please respond only once, otherwise it is getting difficult for us also to keep a fair view. Okay? So let's get started. First question for Team BSL. A 50-year-old man with obstructive sleep apnea has been intermittently using continuous positive airway pressure device. Shows signs of cyanosis. ABG on room air shows pH of 7.31, PCO2 of 70 millimeters mercury, PO2 of 50 millimeters mercury. The most likely finding is, your options are time is up. No points, but you can say if you want.
Ma'am, increase hemoglobin concentration.
Yes, that is correct. No plus, no passing, no marks. पेन तो मिल गया पहले ही पहले ही मिल गया
Negative.
Wrong answer, negative.
Okay, so the next
Next question.
next question,
To team.
Team Vishakhapatnam. A 62-year-old man with COPD presented with acute shortness of breath, which precipitated while he was trying to blow candles. He was apparently well 45 minutes earlier. His pulse is 110 beats per minute, respirations are 28 per minute, blood pressure is decreased 88/64 millimeters mercury, SpO2 is 88%. On physical examination, the trachea appears to be shifted to the left. Pulmonary examination of the right chest is most likely to show which of the following findings with respect to fremitus, percussion, and breath sounds. Your options are time is up.
Answer is D.
No, sir.
No, sir. Answer is B. Parameters decrease, breath sound decrease, and percussion hyperresonance.
Yes, that is the correct answer. Please give a big round of applause. We
pen,
cannot
pen.
give you any
Pen.
pen, sir, for the audience, sir.
Two pen.
This is a case of pneumothorax.
Yes. Due to blowing of the
Yes,
balloon.
due to blowing of the
balloon,
yes.
it is pneumothorax.
Okay, now question for Team Durgapur. Ready? A 28-year-old female at 34 weeks gestation presents with a headache, blurred vision, and right upper quadrant pain. Blood pressure is 165 upon 110 millimeters mercury. Labs show platelets of 80,000 per microliter, AST of 150 per liter, and LDH of 800 units per liter. What is the definitive treatment for this patient? What is the definitive treatment for this patient? Your options are
C.
correct answer. 10 points to Team Durgapur. If nobody has understood, that was a round of applause. Because this is a case of preeclampsia with severe features, HELP syndrome. Yes, correct. So the next question is for Team Bhilai. A 2-week-old male newborn is brought to the office for a well-child examination. He was delivered following an uncomplicated spontaneous vaginal delivery at 41 weeks of gestation. The mother has no history of serious illness and did not receive prenatal care. Her only medication is a prenatal vitamin. She has consumed large amounts of vodka nightly for 10 years. Which of the following examination findings is most likely to be present in this patient? Your options are time is up. Okay. So anybody?
Limb hypoplasia.
No, sir. Yes, that is the answer. This is a fetal alcohol syndrome. Okay, so the next question to Team Rourkela. Are you ready? A 51-year-old man presents with a 2-centimeter left thyroid nodule. Thyroid scan shows a cold lesion. Fine needle aspiration cytology demonstrates follicular cells. Which of the following is the most appropriate initial treatment for the patient? Your options are time is up. Anybody from the stage?
D नहीं C होना चाहिए.
The time is up, sir.
फॉलिकुलर है तो वो
What? Time is up. We won't be giving marks. I'm just asking what is the... See, let's see. Bomb has exploded. Yes, that is the correct answer. But unfortunately, they're not getting marks. Okay, so next, Team Tata. Sir, ma'am, you're ready? A 24-year-old male presents with sudden onset severe testicular pain. On examination, the testis is high riding and the cremasteric reflex is absent. Elevation of the scrotum does not relieve the pain. What is the most likely diagnosis? Your options are correct answer. 10 points to Team Tata. Next question for Team ISCO, ISP. A 47-year-old man with type 2 diabetes mellitus and sickle cell anemia presents to the clinic for a routine follow-up. Which of the following tests can most accurately assess short to intermediate term glycemic control in this patient? Your options are
C.
Answer is C.
C. You are saying C.
B.
Yes, fructosamine is correct, but unfortunately, -5 to Team ISP and no points for Team Visakhapatnam. Although you were correct. Please give a big round of applause for Team Visakhapatnam. Okay, so Dr. Deepak, please ask the next set of questions.
Next question is also for Team ISP.
No,
A 40-year-old male with history of daily alcohol consumption for the last 7 years is brought to the hospital emergency room with acute onset violent behavior and tremulousness for few hours. There is history of him having missed the alcohol drink for last 3 days. What is he mostly suffering from? These are your options.
Delirium tremens, B.
Delirium tremens is correct answer. Next question from Team Tata. A 45-year-old female chronic smoker presents with dry cough and hoarseness of voice. Chest X-ray shows mediastinal mass. Laboratory results shows a serum sodium of 125 milliequivalent per liter and high urine osmolality. What is the most likely paraneoplastic syndrome? Your options are syndrome is wrong.
SIAD.
SIAD will be the right answer. Here, hyponatremia was the clue. And -5 for Team Tata. Next question for Team Rourkela. A 60-year-old woman with type 2 diabetes and hypertension presents for a follow-up. She reports compliance to her regular medicines, which are empagliflozin, metformin, and lisinopril, and good glycemic control based on her home monitoring. Recent lab results reveal normal renal function, hemoglobin of 8.9 gram per dl, MCP of 78, and HbA1c of 8.5%. Hemoglobin electrophoresis is also normal. Her peripheral blood smear shows increased red cell distribution with microcytosis and anisopoikilocytosis. What is the best next step for this management of this patient? Your options are 10 seconds remaining. Time's up. Yes, C is the right answer. Next question for Team Bhilai. A 65-year-old male presents with sudden onset severe tearing chest pain radiating to back. His blood pressure is 180 by 100 in right arm and 145 by 90 in left arm. A chest X-ray shows widened mediastinum. What is the most appropriate next step in management? Your options are
administer intravenous beta blockers.
what?
A.
A. Administer IV beta blockers. That is correct answer. This is a case of aortic dissection, so immediate control of BP is mandatory here. Next question for Team Durgapur. A 24-year-old woman brought to the physician 1 month after she was involved in motor vehicle collision that left her unable to walk. There is weakness and increased muscle tone in the lower extremities. Deep tendon reflexes are normal at the biceps and triceps, but increased at knees and ankles bilaterally. Babinski sign is also present. Sensation to pinprick is absent from upper chest at the middle aspect of forearm and axillary region. The lesion in this patient is most likely located at which level of spinal cord? Your options are
C7.
That is your final answer, which is wrong. Here the correct answer is T1 because the -5 for Durgapur. Here the clue was the sensory abnormality in axillary region and the middle aspect of forearm. Next question for Team Visakhapatnam. A 4-year-old child is brought to the emergency department with high fever, barking cough, and inspiratory stridor at rest. The child is sorry. A 4-year-old child is brought to the emergency department with high fever, barking cough, and inspiratory stridor at rest. The child is agitated and using accessory muscles. What is the most effective immediate treatment? Your options are
So it's 4 D.
D. D is wrong answer. The correct answer will be the nebulized epinephrine corticosteroids. He is suffering from laryngotracheobronchitis or croup. So the immediate goal of management is to relieve the laryngeal edema. -5 to RINL. The last question is for Bokaro. A 72-year-old woman with atrial fibrillation presents with sudden onset severe periumbilical pain. Her physical examination is notable for pain out of proportion to the exams, with no peritoneal signs. What is the most likely diagnosis here? Your options are
C. Acute mesenteric ischemia.
acute mesenteric ischemia is correct. It is a rare complication of atrial fibrillation. Plus 10 for Bocaro. So we have come to conclusion of the second round. We have 2 questions for the audience. Before that, the scores after the second round. Team Bhilai has 30 points. Team Bokaro has 25 points. Team Durgapur and Team Raurkela and Team Tata all share 15 points. Team ISP at 10 points. And Team Visakhapatnam has minus 5 points. Dr. Patil sir, please clarify.
Yeah, you had 5, minus 5. We lost minus 5, and then we answered a question.
10 points. ISP 10 points.
ISP has 10 points. This is the question for the audience. A 5-year-old child presents with ptosis, diplopia, dysphagia and descending flaccid paralysis. He is afebrile, alert and has dilated pupils. There is history of consumption of home preserved food few days earlier. What is the most likely diagnosis? Who said botulism?
No, but if you all say no,
Ma'am,
but
ne
you will get the-
I think the Madam. There is another question. Census abstract of a district report shows median population of 2,50,000, live birth 5,000, stillbirth 300, neonatal death 120, postneonatal death 80, under 5 deaths 260. What is the infant mortality rate? Your options are what?
40. Press 40.
40 is right answer. So now for the commencement of round 3, I will ask Dr. Somorapur to start the round.
PPT is not coming. Yes. We have test questions for that. Okay, so this brings us to the third round, which is called Picture Perfect. This is an image-based round. You will be given 14 images one by one with clues to the question or the question itself. This is a buzzer round. So hands on your buzzers. May the fastest finger win. We have 2 test questions to test whether your buzzers are working fine and you're okay with it. Okay?
Marking.
Marking is correct answer will give you 10 points. Incorrect answer, wrong answer, or if you buzz and do not answer, minus 5. Okay?
Before asking the question, give the question as a buzzer.
If you press the buzzer before I ask the question, then either you have to guess the question and answer the question, or you do not get a chance anymore, okay? And you have to, and that too after the timer starts running. If you press the buzzer before the timer starts running, then you will be disqualified from that question. Okay? Before the timer starts, nobody will press the buzzer. If by any chance you press the buzzer before the timer starts running, then you will be disqualified from that particular question. Fair enough? Okay. Zero. No negative, just disqualified. No negative for that.
No negative.
No negative for that case. In that case, if you buzz before the timer starts running, you will be disqualified from that question, but no negative.
Okay, okay, ma'am.
Negative or positive will start after the timer starts running.
Okay.
Fair enough? Test question 1. You can see who has pressed the buzzer. Team BSL is disqualified. Timer hasn't started running. Yes.
So the question gets scrapped?
Question will not get scrapped. You will get disqualified.
That particular team will get disqualified.
Yes. Question will not get scrapped. You will wait for asking the question. Okay? If in case the timer starts running and you press the buzzer by mistake, after the timer starts running, you have to answer without listening to the question. Okay? What is the likely diagnosis? Your time starts now. Just a second. Team RSP had pressed the buzzer first. Yes. For the test question, we are testing the entire scenario. Yes, sir. Okay, sir? Answer ho gaya tha. We have one more test question. Please wait for the buzzer. Otherwise, if you answer without seeing who has pressed the buzzer, then what will happen? That team might not have known the correct answer and your prompting will help them. Okay? So the next test question. What is the likely diagnosis? Your time starts now. Team RSP again. Correct. Correct answer. Okay? So, all have agreed? Okay with everybody? Timer will start running after I say time starts now. Buzzer. Okay? Hands on your buzzer. May the fastest finger win. This is the karyotype of a person who has pressed. Team ISP is disqualified from this question. Timer has not started. Please clear the time. We haven't asked. What is the genetic abnormality seen here? Your time starts now. Team Durgapur.
Turner syndrome.
Anyways, this answer is wrong. So you cannot give -5 plus -5, so it's just -5. They'll get -5. The answer is wrong. Answer is Klinefelter syndrome. 47 XXY. He has got -5. That's it. Okay, so the next question. There's no passing. No passing, it's a buzzer round. Questions are easy. Just wait for the questions, wait for the image and the questions, okay? And start the buzzer after the timer starts now, okay? Next question. A blood picture. Team Visakhapatnam is qualified from this question. Okay, for the other 6, what is the abnormality seen in this blood picture? Time starts now. You have pressed the buzzer before.
RSP.
ISP has pressed before the question
Ma'am.
was completed.
Press the buzzer before Sri said the time starts now.
तो क्वेश्चन तो फिनिश कर दिया -5
RSP will not be allowed to answer. So the next buzzer was pressed by Tata. You please wait for me to finish. Your time starts now.
Sickle cell.
Yes, correct. 10 points to Team Tata. Okay, so the third question, please wait for me to finish.
Here is the time starts now.
Yes, yes. This is the image of a person trying to grasp something out of a boy's mouth. Just wait for a second. Okay, done?
अब तो आपका क्वेश्चन हो गया ना?
नहीं मैडम
I have not asked the question. Okay, it's okay. Nobody is disqualified from this because I had asked for some time. You are okay with it? System is okay? Okay. A person is trying to grasp something out of a boy's mouth using his fingers. Can you guess this procedure performed in the early 1800s? Your time starts now.
The person is trying to remove.
Pseudomembranous of diphtheria.
Correct answer. Plus 10 to ISP. Sorry, ma'am. ISP, ISCO. Slow. The questions are extremely easy. That's why we have placed the buzzer to make things more interesting.
Buzzer is playing the game.
Buzzer is playing the game. The finger is playing the game, actually.
ये तो वही है.
Okay, so let me go to the question number 4. You're ready?
Tata and ISP both are disqualified. Tata and ISP.
वो तो सर हमने टाइम मांगा था इसीलिए सर. हाँ? That is after the timer starts running, ma'am. Name the sign.
Mount Fuji.
BSL. You will
Wait for them to ask the question. Why you are jumping on guns?
Pneumocephalus, Mount Fuji sign.
Yes, I didn't say. I
Madam
didn't say
was
actually.
saying to us.
अभी तो टाइम स्टार्ट्स नाउ बोला ही नहीं आपने. इस बार मैम आपने टाइम स्टार्ट्स नाउ नहीं बोला.
Okay, we'll cancel the question. Okay? Satisfied?
Get the rules correct.
Please, from this question onwards, no more rule breaking. Okay? Which nerve is involved? Your time starts now. Team ISP.
Serratus anterior. Nerve to serratus anterior.
not enough.
Long thoracic nerve of bell. गजब हाल है. Wrong answer.
What was the nerve involved I had asked?
हाँ, long thoracic nerve of bell.
Wrong answer. Wrong answer.
Nerve to serratus anterior. Nerve to serratus
Person
anterior.
is correct. Then he said long thoracic nerve.
Wrong. Serratus anterior is not a nerve.
नर्व टू सेरेटस एंटीरियर तो कहते हैं सर, ये तो गड़बड़ बात है, ये गलत बात है, ये तो टांग खिंचाई हो रही है ये।
We'll wait for our moderator for this.
No, it cannot be minus, भाई। नर्व बिल तो भूला मैंने मैम, ऐसा थोड़ी और के बोलने पे बोला। नर्व दोनों ही चीज बोला मैं, नर्व टू सेरेटस एंटीरियर एंड लॉन्ग थोरेसिक नर्व बिल।
We'll rely on our moderator for this one. Moderator is there for these situations. Sir, your decision will be final. Points, okay. Points to ISP. ISP, 10 plus 10 to ISP. Okay. Done? Next question. These cells are named after this famous doctor, one of the first female residents at Johns Hopkins. What are the cells called? Your time starts now. Team BSL.
Orphan Annie nuclei.
Reed Sternberg cells. -5 to BSL. BSL. सर सेल तो सर आप बस न्यूक्लियस का नाम बोले सर। Next question. Image shows a plant and its seed. Poisoning with this can cause tonic-clonic convulsions, opisthotonus. A characteristic facial feature is commonly seen in this poisoning. What is the name of the poison? Your time starts now. RSP.
Belladonna.
Ma'am, it's strychnine, I think.
It's strychnine. -5 to RSP.
+5 to...
No, this was not a passable round, sir. Okay, so next questions will be asked by Dr. Deepak.
Okay, I will move on to the next question. This is a hand of an old person. What is the deformity seen here? Your time starts now. Team BSP has pressed the buzzer.
Swan neck deformity.
Swan neck deformity is correct answer. +10 to BSP. Next question. Image of a hand showing some salient characteristic feature. What do you see here? Your time starts now. Team ISP has pressed the buzzer.
Simian crease and Down syndrome.
Single A, yes, that is the correct answer. +10 to ISP. Okay, next question. Image of an old man whose face turns red with certain maneuver. What is the sign? Your time starts now. Pemberton sign is correct answer. +10 for RSP. Next question. picture of an eye showing something in the iris. The question is, what is the gold standard test to diagnose this disease? Your time starts now. Team Tata has pressed the buzzer.
24-hour urine metanephrin copper level.
So that is not the gold standard test. -5 for Team Tata.
Sir, I think it is.
The gold standard is liver biopsy. This is a KF ring hallmark feature of Wilson disease. Next question. This is a steps of glycolysis. There is the question is, what is the enzyme involved at the third step? Your time starts now. Yes, Team ISP.
Isomerase, fructose isomerase.
What? No, that is wrong answer. -5 for Team ISP. The answer is phosphofructokinase. The next question. There is a blood stain on a bed sheet. It is a otorrhea following a head trauma. The question is, what is the sign? Your time starts. Team RSP has pressed the buzzer. Your answer, please.
That is a CSF mix, so it is spreading CSF rhinorrhea.
What is the sign?
Looks like a red omelette. Spreading.
Your time is over. The correct answer was halocine.
Halocine.
-5 for Team RSP. Okay, the next question. No, I asked what is the sign. You have named the sign.
Halocine.
This is a plant which yields a cardiac poison. The question is, what is the mechanism of action? Your time starts now.
Cardiac glycoside.
What is the mechanism of action? What is the mechanism of action, sir?
It's a glycoside.
How does it work? How does it affect the muscle?
Increase the contractility and positive chronotropic effect, inotropic effect.
No, sir, that is not the exact answer.
I think it's
Answer is correct. It's a glycoside, na?
The answer is correct, but what is the mechanism of action? The time is over.
Is it sodium potassium?
So I have to give you -5 points. The answer is
Sodium potassium.
it acts on the voltage sensitive sodium channels, which causes persistent activation of sodium channels, which renders them refractory. -5 for Team Bokaro. Okay, we have asked all 14 questions. Now the time for the final scores after the 3 rounds. Team BSP has 40 points. Team ISP has 35 points. Team Tata has 20 points. Team Bokaro and Team Raurkela shares 15 points. Team Durgapur has 10 points. And Team Visakhapatnam has -5 points.
Please clap for everybody. They are trying really hard. This can happen to anybody.
Now we move on to our final audience round. We have 2 questions for you. This is a image showing a famous advertisement from a old radio manufacturer. The question is, there is a clinical sign that shared its name with the radio manufacturer. What is it? Murphy's sign is correct answer. Our next question. You are all familiar with the famous TV show Dr. House. He has a history of substance abuse. The question is, name the composition. Name the composition, please, madam. Vicodin is the pill, but you have to name the composition. Anyone from the?
Methamphetamine plus codeine.
Yes, acetaminophen and with hydrocodone. Yes. Okay, we now proceed for the next phase of the quiz. There are 2 rounds remaining, which are very high intensity rounds. I invite Dr. Shomorupa to commence the next round.
No, you do not worry, you will get a chance to catch up with this round. Next we come to the 4th round, known as tachycardia, or the rapid fire round, because it will get your heart racing. 5 questions will be asked to each team. You will get 5 seconds to answer each question. There's no negative marking. 10 points for a correct answer. No negative marking, okay? But just keep in mind, you will have 5 seconds to answer the question. Yes. Last answer will be taken then, okay? Timer will be shown on the PPT. Timer will start after I finish the question. Only 5 questions, 5 per team. Per team will be asked 5 questions. Okay, so this time we have to start with Deepak. Last किससे start हुआ था? कहाँ से हुआ था? Last यहाँ से. So this time we have to start from with team ISP. Okay? 5 questions per team. No negative markings. So you will get a chance to catch up with this round. This is a test question to show you how it is done. First question, first non-European to win a Nobel Prize.
I can say
Understood? Anybody from the audience? Correct.
हम लोग दे देंगे हम लोग दे देंगे
5 seconds है
Okay, so the next test question. Where was the first blood bank set up in India? Nobody has answered. Not entirely true. It was in School of Tropical Medicine actually. By Sir Upendranath Brahmachari. Okay, so everybody familiar? You have to answer within the 5 seconds. If it comes to 0, your answer will not be taken, okay? Clear? Team Burnpur, you're ready? Okay. Thinking caps on. First set. Delta wave on ECG is seen in?
Deep sleep. Delta wave. Wolff Parkinson's White syndrome.
Correct. Plus 10. Drug of choice for anaphylaxis.
Adrenaline. Epinephrine.
Correct. 10 points. Next question. True or false? Vitamin K deficiency can lead to an increase in APTT.
Wrong.
You're saying false. No, that's incorrect. In severe cases, it is true. It is mostly false, but in severe cases, it can also lead to a raise in APTT. Okay? Next question. First permanent tooth to appear.
Central incision.
No. Please, sir. Correct, sir. Sir, we are out of. The audience is too intelligent, so we are out of our prizes. Yes, sir. We can keep it on loan. Last question for Team Burnpur. White line of Frankel is seen in which vitamin deficiency?
Vitamin C.
Correct answer. Plus 10. Plus 10 for this question, individual question. Total 30. Total plus 30. Okay? Okay, give a big round of applause for Team Burnpur. Okay, so now we have Tata. Sir, ma'am, you're ready? Thinking caps on. First question. First organ to putrefy is?
Skin.
Brain.
No, ma'am. It's larynx and trachea. Second question. Most common organism causing tinea versicolor is? Malassezia furfur. Third question. What is known as the golden blood group?
O positive.
Anybody from the audience? No, you're so far from the correct answer. Not at all.
Bombay blood group. RH negative.
No, ma'am. No, sir. It is RH null. RH null is called the golden blood group.
And that's why that is golden arm of
Yes.
James Harrison.
Yes. Okay. Next question. BCG vaccine is derived from?
Bacillus calmette.
That is the full form, madam. Live attenuated Mycobacterium bovis. Even Mycobacterium bovis would be considered right answer. Last question. Name one 5th generation cephalosporin. Anyone?
Cephalexin.
No, sir. It is ceftarolin or
Ceftaroline or
ceftobiprole.
ceftobiprole.
Yes, sir. Okay, so Tata is yet to score. Okay, so please give a big round of applause to Tata. They have tried really hard. Okay? So now team Raurkela, ready for your set of questions? These were the answers of the second set. Okay. So the first question, enzyme inhibited by acetazolamide is?
Anhydrase. Lactate anhydrase.
It is carbonic anhydrase.
Enzyme.
No, sir, I cannot give you this, sir. There are lots of anhydrase, sir. Yes. No negative marks as well. Next question. Bamboo spine on X-ray is seen in?
Ankylosing spondylitis.
Correct. Plus 10 to team Raurkela. First temporary tooth to appear is?
Incisor. Central incisor.
Correct. Lower central incisor or central incisor. Sometimes it becomes upper central incisor as well. So 10 points to team Raurkela. Fourth question. Etiology of erythema infectiosum is?
Rheumatic fever. Rheumatic fever.
No, incorrect. Okay, the last question for team Raurkela.
Fifth disease.
Yes.
Parvovirus.
Parvovirus. Yes. Melanoma is a radiosensitive tumor. True or false?
False.
Correct. 10 points to team Raurkela. Give a big round of applause from team Raurkela, please. You have got 30 points. 30 points in this round. Okay, so next team Bhilai. Ready? Mechanism of action of heparin.
Factor 10A inhibitor.
No. Activates antithrombin 3. Second question. What is Cotton's fracture? It is fracture of ankle, actually trimalleolar fracture of ankle. Third question. Causative organism for scrub typhus is? Time up. Yes, Orientia schusugamis is the correct answer. Fourth question. Pancreatic cholera is caused by? It is a tumor, VIPoma, VIP secreting tumor, VIPoma. WDHA syndrome. There's no negative marks. You can say anything. Last question for team Bhilai. Blisters can be present in post-mortem burns. True or false?
True.
Correct. True, but they are false blisters actually. So 10 points to team Bhilai. Give a big round of applause for team Bhilai, please. Okay, so our home team, Team Durgapur. Ready? Home ground. Okay, let's start. Antidote for paracetamol overdose is?
N-acetylcysteine.
Correct. N-acetylcysteine is the correct answer. 10 points to Team Durgapur. True or false? Phase 1 of clinical trials is performed in animals.
True.
No prompting, please. Lots of supporters.
Time over.
Time is up.
Time over.
True bola hai na? The answer is wrong actually. So no worries, the answer is wrong. It is actually false. Okay. No worries, please relax and answer. No negative marking, that is the USP of this round. Okay, so the third question for Durgapur. Which bone is affected in Kienbock's disease?
Vertebra.
No, it's lunate. Fourth question. Most common benign liver tumor is?
Hemangioma.
Correct, hemangioma is the correct answer. 10 points to Durgapur. Last question for Durgapur. Name a virus causing Burkitt's lymphoma.
Epstein-Barr virus.
Yes, correct. Epstein-Barr virus. It is Epstein-Barr virus, HHV4 or HIV. Any of the three would be acceptable. Okay? So, Durgapur has scored how much? 30 points for Durgapur. Please give a big round of applause. Visakhapatnam, please relax. No worries. There's no negative marking. Please attempt. And the last answer will be taken within the 5 seconds time. Drink some water if you want. I'll drink some. Anybody needs water? You need water? We'll get you one. हाँ? काफी पानी पिला दिया. Okay, so audience, are you enjoying? Or you're getting bored? Okay. Okay, so we'll start with Visakhapatnam now.
Yes, ma'am. कुछ नहीं है. नहीं, उसमें आंसर करना.
Questions for team Visakhapatnam. Question 1. Selective medium for Vibrio cholerae is? It is TCBS or TTGA. Second question. Drug of choice for paroxysmal supraventricular tachycardia or PSVT is?
Adenosine.
Yes, correct answer. Adenosine is the correct answer. 10 points to Visakhapatnam. 10 points to RINL. Third question. A snowstorm appearance on pelvic ultrasound indicates? Time is up, sir. Sorry. Very sorry. Hydatid. Molar pregnancy is correct, actually. Okay? Fourth question to Visakhapatnam. Angel dust refers to which drug of abuse?
Heroin, madam. Heroin, madam. Heroin.
No, it's phencyclidine. Last question to Visakhapatnam. Receptor defect in Glanzmann's thrombasthenia is?
G1B.
No, it is GP2B3A. 1B is something else. 1B is the other one, actually. Okay, so big round of applause for team Visakhapatnam. They have scored 10 points in this round. So the last set for this rapid fire of today, facing team Bokaro. Supporters of team Bokaro, please give a big round of applause. You can see them, no? They are actually sitting in a blind spot. Yes. Okay. So the last set of questions for this rapid fire of today to Team Bokaro. Question 1. Antidote for benzodiazepine overdose.
Flumazenil.
Correct answer, flumazenil. 10 points to Bokaro. Most common site of an ectopic pregnancy is? On the mic. You have answered correctly. He has actually answered correctly, but he hadn't the mic. Isthmus of fallopian tube. Yes, okay, I'm giving you the points. Why are you fighting with me, sir?
Thank you, ma'am. Thank you.
I am for you. Yes. Do not worry. 10 points to Team Bokaro. I was saying actually nobody could hear it. He hadn't the microphone in his hand. Both of you have the microphones, okay? Third question. Half and half nails seen in? Time is up.
Hypoalbuminemia.
That is an incorrect answer and the time is also up. Anybody? Renal failure. Fourth question. Foxglove refers to which poison?
Glycoside.
It's a common poison actually.
Aconite.
Correct, sir. Give him a big round of applause, please, to Dr. Ashim Bose. Digitalis purpura is the correct answer.
Glycoside bola tha, ma'am. Digitalis is a glycoside.
Sir, you have to name the poison, sir.
Sir, glycoside is a group which digitoxin and digitalis is a...
Sir.
It's a glycoside, sir.
Sir, it is a name of actually a particular poison. All glycosides are not known as foxglove.
Okay, ma'am.
The last question for this rapid fire today for Team Bokaro. Osgood-Schlatters disease affects which bone? No prompting, please. No. Tibial tuberosity. Okay, and so the Team Bokaro has scored how many points in this round? 30 points in this round, Team Bokaro. Please give them a big round of applause. Do correct hua? Oh, sorry. I'm very, very sorry. Bokaro has 20 points. Anyways, please give them a big round of applause. Okay, so the scores at the end of this round. Team Burnpur leading with 65 points. Team Bhilai with 50 points. Followed by Rourkela with 45 points. DSP is close behind with 40 points. After that is Bokaro with 35 points. Tata with 20 points. And Vishakhapatnam with 5 points. Please give them all a big round of applause. Thank you, everybody. So now we come to our last round. Over to Dr. Deepak for that.
We have came to the concluding round of our quiz session. This round, the this will be once again a buzzer round, but it will be different from the previous one. There will be 7 questions. Teams, listen to me. It is again also a complicated round. There will be 7 questions. Each question will have two parts. Okay. The first team to press the buzzer will have to answer both the parts. There are 5 points for each part. That is, if you press the buzzer and get the answers correctly, you would get 10 points. If you press the buzzer and get both the answers wrong, you will get minus 10 points. And if you, yes, if you press the buzzer, get one question but unable to answer or answer incorrectly another question, you will get 0 points. Okay? Okay. Okay, yes. Again, I will say your time starts now. Then?
Sir, both the question will be asked, then the buzzer will start.
Yes, I will, the questions will appear and then I will say your time starts now. Then you can press the buzzer.
If somebody knows only one question, one answer to the question.
That I said, you can answer one question, but you have to answer another question. If it is correct, then you will get total 10 points. If it is incorrect, you will get 0 points. Either incorrect or if you are unable to answer, then that will be total marks of 0. If one answer is correct, you have to and they have to answer both the questions.
Excuse me, hello.
There will be no points.
But लिखा हुआ है इसमें correct answer 5 plus 5. Each question carries 5 marks.
Each question carries 5 marks.
If the first answer is correct, but the second is wrong, the marks will be 0. If you have answered first correct, second also correct, 10 points. If you have answered both wrong, then minus 10. If you haven't answered, that also minus 10. No pass. Buzzer. I think everyone is clear.
Any doubts? Anybody can ask. Any doubts regarding this time?
If only one question is answered and the second question is not answered,
then plus 5 and minus 5, which rounds to 0.
No. Second question is not answered. He didn't attempt at all.
Minus 5. So plus 5 and minus 5 comes to 0.
The idea is you have to get both the questions. Any question from the participants? I am asking again, if there is any question, you can ask me.
Pass on to the next buzzer participant?
No passing.
It's no passing.
This has so any questions again?
Sample question.
I have a simple question. This round has been made complicated because it is a final round and it will be our deciding round. So we move on to the sample question. So okay, I am. A young man develops ascending weakness 1 week after diarrhea and has absent diphtheria reflexes on examination. Your questions are, your time starts now. Now you can press the buzzer. And
Guillain-Barré syndrome, GBS, and first line of management is immunoglobulins.
Yes. So that's how the questions will be answered.
And in this case, they would have got 10 points. But because this is a test question, no points for that. You will get our good wishes, sir.
So if all are ready, I will start the round.
Please press on the keyword and now your time starts.
Keyword is time starts now.
The time starts.
Time starts now.
Now के बाद
Yes, sir. Now के बाद.
करना है, please.
The first question. A 10-month-old infant is brought in with bouts of excessive crying, where he draws his knees to his chest, followed by periods of lethargy. His mother noticed a currant jelly stool a sausage-shaped mass is felt in the abdomen. Your questions are, your time starts now. Team ISP has pressed the buzzer.
Hirschsprung's disease.
It's a volvulus actually.
You have to decide your answer.
Volvulus it is. Sigmoid volvulus.
Audience, please keep quiet.
Your time is up.
Time is up.
The time is up, sir.
Volvulus is current.
Now, audience, you can ask. Now, you audience, you can answer.
Target sign in ultrasound. Interception target sign.
Interception and target sign.
Time is up.
That
but
was the answer.
They get minus 10.
ISP will get minus 10 points.
Diagnosis.
If there is any question from the audience, we will answer for you.
Audience request you to please stay
सर
quiet.
वो भी तो टाइमर के बाद बोला ना.
Okay, I will move on to next question. Most West Africans are resistant to Plasmodium vivax malaria. The questions are, your time starts now.
Team Visakhapatnam.
Answer both the questions.
Both the
You have 10 seconds remaining.
G6 deficiency. No. Duffy blood.
Your time is up.
0. Anyone from audience?
Plus 5 minus 5. Duffy bulletin.
So they will get no points for this question.
Plus 5 minus 5.
They said Duffy.
They said Duffy.
Now we move on to next question.
Actually, it is Duffy negative.
The association between low birth weight and maternal smoking during pregnancy can be studied by obtaining smoking histories of a woman at the time of their visit and then subsequently correlating birth weight with smoking histories. The questions are, your time starts now.
Audience, please, they are trying to think. I would please request you to please no murmuring.
Okay, the time is up. It is a cohort study, and odds ratios can be calculated in cohort studies where the prevalence is low, that is less than 10%. I'm moving on to next question. Vitamin B deficiency causes subacute combined degeneration of spinal cord. The questions are, your time starts now.
Tough as hell.
Okay, so no one answers.
Someone press the buzzer. BSL.
Why the term combined? Because it involves two tracts. One is peripheral, means posterior column, and another one is pyramidal, corticospinal. So it's a combined. And why the term degeneration? Because it is degeneration of the nerve fibers.
Okay, I will give you that.
Good, good.
So plus 10 for team Bokar.
Plus 10 for BSL.
Next question. An 80-year-old male patient presents with triad of urinary incontinence, gait instability, and progressive dementia. Your questions are, your time starts now.
Sanism?
Sir, please.
Sir, please.
मैडम नेगेटिव तो आएगा ही, दे दो ना.
Okay, time is left. You can answer. Timer is running.
हाँ, दे तो दो आंसर.
Ataxia, injury, and dementia.
Your time is up. Yes, this is a case of NPH. The bedside
Normal
procedure is
pressure, hydrocephalus.
therapeutic spinal tap.
Minus 10.
Minus 10.
The answer is normal pressure hydrocephalus, and the bedside procedure is therapeutic spinal tap. So, okay, I now move on to the next question. A mother said her baby tastes salty when kissed. The questions are, your time starts now.
Yeah, gene mutation.
Okay, that is correct answer.
Correct answer. Plus 10 to Team Tata. Please don't be stingy with your claps. They have been sitting for a long time.
Our next question. A 29-year-old female presents with history of unintended weight loss despite an increased appetite. She reports feeling of anxious and jittery, and her hands shakes when she draws. Her vital is heart rate 110 beat per minute, BP is normal. She has a diffuse non-tender enlargement of her thyroid and fine tremor of outstretched hands. The questions are, your time starts now.
Can't see the question, so please read it.
Answer. Thyrotoxicosis and why is propanol preferred?
They are answering. Sir, ये लोग देखें. So what is your provisional diagnosis and why propranolol is preferred over other beta blockers in this condition?
Okay, so he is saying thyrotoxicosis, and because it crosses the
Thyrotoxicosis is the
blood-brain
correct answer, but that is not why propranolol is preferred. Propranolol is preferred because it blocks 5-pontodeoxygenase, which reduces the conversion of inactive T4 to active T3 in peripheral tissue, thereby reducing its toxicity. So there is no point for Team Visakhapatnam.
But please a big round of applause from them. They have at least answered partly correct, and it takes guts to do that.
Seven questions were there. So for final score and winner announcement, I asked Dr. Somarupa to come to stage.
Okay, so no points for guessing. Who is the winner? Supporters of Burnford. Give a big round of applause to Team ISP Burnford. And thank you, audience. You have been a lovely audience for this. Your claps were immeasurable. And so, okay, so first position goes to Team Burnpur, ISP. Second position goes to Team Bhilai, DSP. Please stand up, sir. Big round of applause for Team Bhilai. And in the third position today, we have Team Bokaro. Please come forward, sir. Nobody has been able to see you. And I'm sorry, we have a tie with Team Rourkela for the third position. Everybody please come into the center stage for a group photograph. All the participants, please. And please a big round of applause for all the other participants as well. It takes immense guts to sit here for this quiz, facing all 7 hospitals and so many of esteemed faculties. Please, moderator sir, please, you to come up on the stage. Patil sir, please come up on the stage. One second, please, somebody click a photo in my camera.
Participants, please collect your t-shirts from us.
Participants, please collect your t-shirts from us. You have taken great efforts for customizing t-shirts.
I'd like to thank my quiz masters, Dr. Deepak Singh and Dr. Soumyarupa Maji, for nicely conducting this thing. Give them a big round of applause.
Somebody has taken, we have an ISCO t-shirt here. Somebody from Team Burnpur has taken somebody else's t-shirt. Burnpur. बोकारो नाम लिखा है सर सामने छोटे करके Team Durgapur. Sir, colors are all same. The names are different. Names are in the pockets. I have Durgapur with me. Durgapur, I'll keep with me. Thank you so much. Thank you so much.
এর পরের সেশনে এখানে কটা চেয়ার আছে? দুটো চেয়ার এখানে দিয়ে দাও।
আমার এখানে আমার এখানে আমাদের প্ল্যাটফর্মটা আমাকে দেখা যায়
ওই প্ল্যাটফর্মটা নিতাম ওই প্ল্যাটফর্মটা দেখুন উঠে দেখুন উঠে দেখুন ঠিক আছে। এই এখানে ল্যাপটপ
ল্যাপটপটা
এখানে ল্যাপটপ অন কর।
আমার লাগবে না ল্যাপটপ আমার ল্যাপটপ
এর পরের সেশনে
না একটু সেট করে দাও। এক মিনিট দিয়ে দিন।
দুটোই আছে।
দাও দেবে। ভিডিও মানে সেভ করতে
একটা পিডিএফ দুটো
কোথায় দিয়েছো?
এমনি নরমালি দিয়েছি।
কি নাম?
হিমাংশু গুপ্ত, ডক্টর হিমাংশু গুপ্ত।
এটা
হ্যাঁ
পিপিটি চালাবো তো?
একটা পিপিটি আছে আর একটা ভিডিও আছে।
ভিডিও চালাতে হবে?
না প্রথমে পিপিটিটা চালাও, যখন ভিডিওটা করবে তখন ভিডিওটা, দুটো আলাদা আলাদা।
ভিডিও কোথায়? এটা
না হিমাংশু
শেখ
গুপ্ত
শেখ।
আছে ভিডিও।
চালিয়ে নিয়ে এটা বড় ফাইল আছে মনে হয়। 17 MB ফাইলে তো জমা লাগে খুলতে। খুলে গেছে বড় করে দেখুন। সবই করে না বুঝে।
প্রাইস ডিস্ট্রিবিউশন পেছনে কে? তোমাদের লোকই তো ছিল না, সে তো আমাদের লোক আছে। হ্যাঁ
ওরা চাইছে না আমাদের এখান থেকে কেউ একটা থাকে তাপসকে বলি
সুতানু স্যার বলে যায়।
সুতনু জানে তাপসকে জানে দুজনকে বলি সুতনু সরকার আমাকে লিস্ট বানিয়ে দিয়েছে।
অন্য লাস্টে দেয়নি?
একটাই বাকি আছে।
एक बार में दे दीजिए।
কিছু করে আছে।
কোথায় গেল এটা? এটা হিমাংশু গুপ্ত।
মইনা একটু বাইরে সবাইকে বলো সেকশন শুরু হচ্ছে, ভেতরে চলে আসো, একটু ভেতরে পাঠিয়ে দাও। ননি শুরু করতে পারছি এই যার মধ্যে একটা আমার ছিল, কেটে গেল কোনটা আমার ছিল।
ম্যামের জন্য একটা নতুন দিয়ে দেন। এই লাইটটা একটু কমা।
राजीव बाकी सबको आने में बोलो।
দিয়েছে একটা দিয়েছে
না এখানে তার একটা ওটা
ম্যামে এটা ম্যামে এই কুইজ
এখানে থাকুন ভিডিওটা চালাতে।
डॉक्टर आर कुमार सर को तो काम
এরকমই
एटलीस्ट
स्टार्ट
चेयरपर्सन डॉक्टर आर कुमार एंड जयंत कुमार आचार्य, डॉक्टर आर कुमार जयंत आचार्य इस चेयरपर्सन का नाम अच्छी बात है। कुछ आप सुनो आर कुमार सर को
I'm going also.
এদিকে দুটো চেয়ার লাগবে না
দেখে দিলাম তারপরের সেশনটা আছে না আস্তে আস্তে করে আমি রেডি করছি পরের সেশন
পরের সেশনে
মানে 9 এর জন্য আমার অ্যাটলিস্ট 40 সেকেন্ডস লাগে এর পরের সেশনটা এখানে 9 জন বসবে 9টা চেয়ার
স্যার
ঠিক আছে চেয়ারগুলো রেডি করে নেন এতগুলো অ্যাওয়ার্ড কে দিচ্ছে সুতান না সে তো জানি সুতানো স্যার উপায়ন পরের সেশনটা 30 মিনিটস পরের সেশন
Requesting everyone to please be present in the hall for the guest speaker session. Everyone, please. So now we are starting the guest speaker session. The first speaker we have today is Dr. Himanshu Gupta. He has done his MBBS and MS in General Surgery, Fellowship in Surgical Gastroenterology, FMAS, FIA GES, DIP MAS, FALS, HPB. He is a senior consultant and head of the Department of General Surgery and senior consultant of robotic GI surgery of Health World Hospital. May I request, sir, please? And to chair the guest speaker session, I would like to request Dr. R.R. Kumar, sir, CMOIC Durgapur and Burnpur, and Dr. Jayant Kumar Acharya, CMOIC Rourkela Steel Plant, to please be in the podium.
Good morning to everyone. Today, I would say thanks to dignitaries, thanks to everyone, and I would like to thanks to this association giving me the opportunity for presenting this session. So today I am going to discuss on robotics in inguinal hernias. So going back to the history, how the hernia was, like surgery was evolved. Initially, there was basic tissue repair, that comprises of Spessines or Schuldeis repair, that was consisting of high tension and gives rise to a lot of recurrence. But after the coming to the open surgery, the longitudinal tension-free repair, that was a gold standard for the decade, and that prevents the hernia recurrence. Furthermore, evolving into the laparoscopic, there comes as TAPP and TEP, that is transabdominal preperitoneal repair or total extraperitoneal approach, in which there is a minimal abrasive, causing less tissue damage, making a plane, place a mesh, and the chances of recurrence are less as we cover all the area of myopectoral orifice. Then now it's evolving, the thing is robotics. We do robotic surgeries, that is transabdominal preperitoneal repair, that is next level, having the more precision with good ergonomics. Why we should shift to robotic surgery? The limitations of standard laparoscopy is 2D, rather comparing from 3D it's robotic. 2D has the chopstick or effect like rigid instruments, but in the robotics it's endorist technology having the 7 degree of freedom. Ergonomics on the surgeon, like straining of the surgeon in standard laparoscopy for prolonged standing or maneuvering, rather and along with the tremors. But in robotics, the tremor filtration as well as the ergonomics is pretty good. That decreases the surgeon effort basically. So coming to the standard laparoscopy, there's difficult angles of suturing, especially of the flap closures or corner sutures. But in robotics, you can seal or suture at every corner and every area. Even with a small area, you can go in and you can mobilize the tissue and place a suture in that area. So this next level concept is nothing but is about robotics having the vision clarity that gives a pretty maximum zoom rather than laparoscopy with surgical precision, along with the advanced material like combining the 3D mesh gives the optimal effect of the inguinal hernia and prevents recurrence. So coming back to the anatomy, this myopectineal orifice of foregut, everyone knows that is superior is internal oblique and transverse abdominis, inferior is Cooper's ligament or pectineal line, medial is rectus muscle and rectus sheath, and the lateral is iliopsoas muscle. This whole area is very much important because this whole area has to be covered nicely with a mesh. If we don't cover it, then definitely we need to face recurrence. So coming to the critical safety zones like triangle of doom, triangle of pain, and corona mortis. Triangle of doom is bounded by vas deferens and the conotacal vessels. External iliac artery and the vein are the components, and the main risk of catastrophic hemorrhage, as sometimes one can place tacker or suture in that area. So coming to the triangle of pain, there is lateral to the gonadal vessels, and that contains the lateral cutaneous, femoral cutaneous nerve, femoral branch of genitofemoral nerve, and placing a tacker in that area or placing a suture can result in chronic neuralgia or chronic pain to the patient. So coming to the three nerves of the inguinal region, genital femoral nerve, lateral femoral cutaneous nerve, inguinal or hypogastric nerve. Genital branch goes to the deep rings with the cord that carries a sensation to the scrotum or the cremaster, and the femoral branch goes to the vascular lacunae, sensation to the upper thigh. Lateral femoral cutaneous branch courses deeply along the iliopsoas muscle and the mostly risk at the lateral fixation of the mesh. Ilioinguinal or iliohypogastric, typically anterior to the mesh plane in transabdominal preperitoneal repair, but caution during the transabdominal suturing. Coming to the circle of death. Circle of death is called as corona mortis, where the aberrant obturator artery can arise from either of the inferior epigastric or the external iliac rather than internal iliac, that usually crosses the Cooper's ligament. And the most important thing, do not place or put a tacker in that area to avoid injury to the vessels, resulting in death of the patient. So coming to the preperitoneal space, in case of transabdominal preperitoneal repair or total external peritoneal repair, both we need to create the space, that is space of Retzius and space of Bogros. The space of Retzius is basically the space between the bladder and the pubic bone, and this has to be dissected medially 2 to 3 centimeters from the midline or from the symphysis, and space of Bogros is a lateral retroinguinal space that has to be dissected laterally almost 3 to 4 centimeters to at least accommodate the mesh of or a mesh in that area, that like a deep ring has to be covered almost 5 to 7 centimeters to prevent the recurrence. So coming back to the selection of the patients for the robotic area repair, the ideal candidate should be the bilateral hernias, recurrent inguinal hernias, obese patients having the more than 30 BMI, or the complex patients having the scrotal hernias. The only consideration in robotic surgery is the cost, which is little high. Operating room availability requires a bigger space, like for the console and the monitor and the robot patient cart and the robotic arms. And the patient who has gone under extensive lower abdominal surgery, that makes it difficult to re-go. So coming to the pre-operative planning, the patient should be assessed physically, the diagnosis has to be confirmed, followed by imaging like CT or ultrasound, which is not routine but is useful in suspected occult hernias or spiral hernias or complex abdominal wall defects, which are difficult for accessibility. Optimization, smoking cessation, weight loss, glucose control to minimize the infection risk. This is a robotic platform which we use is SSI Mantra platform. This platform has 3 main important parts. One is console, this is surgeon console. As you can see, this is the surgeon console. This is a sort of open console, unlike with the other robotic systems, in which you need to peep in and you need to see the thing until unless it is eye contact is not going to work. But in this case, we have the open console. We can directly see the tissues, everything, and even along with if you have the assistant or you have the co-surgeon, they can sit around and they can see this in 3D vision. Along with that, we have the patient cart, that is arm. Usually one is camera arm and rest three are the working port, or you can say working arm, along with the vision cart. So room setup and positioning, the patient should be in supine position with arms tucked. Position should be slight Trendelenburg, 10 to 15 degree, to move the bowel cephalad. Robotic docking is typically between the legs or the foot or by the side of the arm, depending upon the scenario and depending upon the patient stature. And assistant can have on a side opposite to the hernia or between the legs. So coming to the port placement, the most important thing in the robotic surgery is, unlike the laparoscopy surgery, the port placement is important, because in laparoscopy or laparoscopy inguinal hernia, we make a port in supraumbilical area, but in this case, we at least assess the distance has 20 centimeter from the symphysis has to be taken, and then we need to make a port in supraumbilical region. Otherwise, there will be instrument crowding and can give rise to error. Another two arms, arm 1 and arm 2, that will be in mid-clavicle line, just right or left, 8 to 10 centimeter from the umbilical port or supraumbilical port. And someone requires the assistant port in some cases for suctioning or irrigation, that can be made depending upon the scenario. So coming to the diagnostic laparoscopy, the entry should be with the Hessen's or optical entry, which we do routinely. Insufficient will be kept around 10 to 1250 milliliters of mercury. Inspection should be done to identify the defect, direct, indirect or femoral hernia. Check for the contralateral hernia, especially 10 to 15% of the patient can have found a contralateral hernia on the other side also on laparoscopy, diagnostic laparoscopy. Other issues if required, if bowel or omentum is stuck to the anterior abdominal wall. Creating a flap, in TAPP approach, the incision starts 4 to 5 centimeters superior to the deep ring, extending from the medial umbilical ligament to the ASIS. The main goal is to create a bucket handle flap to expose the entire myopectical orifice. Coming to flap dissection, we can use monopolar like hot scissors or bipolar. Usually in robotics we use monopolar scissors as a for cutting hot scissors, and bipolar on on Maryland or even grasper. Stay in avascular prepaternal plane, there is loose irregular tissue. Angel hair sign indicates the correct loose connective tissue plane, avoiding digging to the muscle or bleeding, or staying to the superficial maybe thin plane. Dissect down to the Cooper's ligament medially and the psoas muscle laterally. The most important part is to identify whether it is direct or indirect hernia. The hernia defect or sac which is medial to the inferior epigastric is direct, but lateral to the inferior epigastric is indirect hernia. Usually a broad weakness in the transverse fascias is found in direct hernia. Reduction often easier with the traction of the prepaternal space, but indirect hernia it travels through the entire ring, internal ring to the cord structure, and that requires a careful dissection or sometimes may require transection of the sac in between. So sac reduction, a gentle traction of the sac with sweeping cord structure can give away. Even we can use hand over hand technique or with the robotic arms that give rise to the, like you can separate the tissue around that and can bring down the sac almost 4 to 5 centimeter below the deep ring. But watch for the vas difference and the gonadal vessels that can encounter in that area and can result in bleeding or injury. So managing the sac, the small sacs or medium sac can be completely reduced to the abdominal cavity. A large scrotal hernia may require sac transection if intimately adherent to the cord structure to prevent testicular ischemia or hematoma. If transected, leave the distal part open to the drain, and that prevents the hydrocele. When it is closed, the proximal peritoneum carefully. So coming to the peritonealization, why it is important? This is a critical step to prevent the recurrence. Peritonealization is the cord element involves separating the cord structure from the peritoneum deep to the pelvis. This ensures the mesh should lay against the psoas muscle and cover the complete deep ring without any tenting of the mesh. Because the mesh is tented, then give rise to recurrence. The mechanics of peritonealization is the peritoneum is not stripped back enough, at least 5 to 7 centimeter from the deep ring. Inferior edge of the mesh will roll up and when the peritoneum is closed. That can result in recurrence, resulting in indirect recurrence for the mesh rolling. The critical view of MPO, before the placement of mesh has to be exposed, like medial border, as pubic symphysis and Cooper's ligament clearly delineated at least 2 centimeters past the mesh line. Lateral is ASIS and the iliopsoas muscle. Inferior is pectineal line and adequate palatalization should be done. Obturator space should be cleared of fat to rule out any obturator hernia. The mesh we use in this is anatomical mesh, that is textile, that is designed specifically for a minimal invasive approach, that is synthesis of the material science as well as the anatomical engineering. This 3D mesh has anatomical compliance, like the mesh is pre-shaped and fits to the complex curvature of the inguinal ligament, inguinal region. It mirrors the contour, it mirrors the contour of the psoas and the iliac and the rectus sheath, and that prevents the folding of the mesh during the peritoneal closure. The benefits of reduce the need of extensive fixation, that minimize the dead space where the fluid or seroma can accumulate, and enhance the patient comfort by reducing the stiffness. So handling and design of this mesh is like sealed edges that prevents the fraying during the insertion through the 8 mm trocar, and maintains the shape memory when pops out inside. The porosity is large pore with polypropylene and promotes the rapid tissue ingrowth of fibroblastic infiltration that reduces the foreign body reaction and chronic inflammation. The orientation markers are visual cues to assist in correct or right or left orientation, and crucial for efficiency in robotic handling. Why we use anatomical mesh or textile in robotic repair is the handling of robotic instruments lack haptic feedback. A mesh that unfolds spontaneously, having the memory reduce manipulation time. Stability, the 3D mesh locks into the anatomy, allowing the fixation free or minimal fixation technique in selected cases. Efficiency is streamlined. The deployment of phase, which can be fidgeted with the flat meshes. Coming to the mesh deployment, sorry, I think time is up. Just a short video. I will go through the short video of, This is a short video of robotic surgery, robotic inguinal hernia, which we have done in a recurrent left inguinal hernia case. You can see very well, we dissected out peritoneum 5 centimeter from the ASIS, created a plane, and dissecting this loose iliac tissue, we gone straight to see the symphysis pubis. And we have created a plane just 2 to 3 centimeter medial to the pubic symphysis, and dissected gradually this area, and we were anticipating the sac will be definitely adherent in that area. So we initially tried to dissect the sac, but when we found it's difficult because of dense adhesion of previous surgery, so we opened the sac and gradually transected in between without damaging the cord structure, inferior epigastric vessels and gonadals. Once this is done, we dissected out till the iliac vessels completely. All the whole fibroiliac tissue you have to remove to place a mesh nicely, otherwise it won't take the shape of the anatomy. So gradually this has been removed, and finally we'll place a mesh in that area and we'll fix it. This is mesh we have placed. This is textile anatomical mesh. You can see it takes the shape of the anatomy basically, and we have done the closure with 30 Vicryl. So the most important aspect is post-operative pain is less. Patient can be discharged with the next day, and patient can return back to the normal activities after 7 to 10 days. So just last slide. My data of almost 14 years of hernia surgery, total laparoscopic hernia I have done is 973. Out of that, robotic and robotic hernia surgery is almost 11. The complication in laparoscopic case, 7 have the neuropathic pain, 2 had the recurrence, 23 had the hematoma, out of that 5 required USG guided aspiration, and conversion to open 5, that is because of bowel gangrene was persistent in that area, and bowel injury or abrasion or unclean anatomy made it convert to open. Subacute intestinal obstruction in post-op period is 5 cases, but till now we not reported any complication in robotic cases, as we started doing hernia in robotics in the last 1 year. Thank you.
Dr. Gupta, there is a coming concept for fixation of the mesh or no fixation of the mesh. Letters are coming. What is your opinion?
Sir, what I feel if we use anatomical mesh, definitely fixation is either required minimal or even no fixation is required, because it takes the shape of the anatomy, and when you close down the peritoneum, it sits nicely in that area. So there is less chances of mesh migration or causing recurrence.
Thank you, thank you, thank you.
Last 2 days we have been hearing about Da Vinci. You have shown mantra.
Mantra.
Just apart from being cost effective, is there any other advantage?
Cost effective, you are saying regarding this mantra and Da Vinci. Da Vinci has actually a console you need to peep in, the surgeon console. But in this,
I am not a surgeon, but just what I understood.
In this, we have like a monitor, regular monitor on your cart. You can very well see, as well as along with you, you can some or the other surgeon or the assistant can sit besides you with a 3D glass and can have a look what you are doing. They can judge or they can guide also. But in SSI mantra, you need to peep in this console, and that results in neck stiffness of most of the surgeons. But in this case, you can relax on the chair, you can just do a hand movement and it will be done.
No, it is more user-friendly.
More user-friendly, what I've seen. Rather, this we are using SSI 3. Initially, we have SSI version 2, which is little bit unhandy. Like this is better version with this thing, SSI Mantra 3.
So, anybody interested to discuss anything?
Yeah.
All advanced laparoscopic surgeries at our center. So do we need to modify our existing OT infrastructure to fit in this robotic system, or we can just bring in this SSI mantra and start the procedure?
There is no modification is required as of now. Just the size of the operating room matters. Rest is movable part. You can move around. You can place anywhere in that area. So there is no, like some says like you need to fix in a wall.
Yeah,
you
that's
cannot
what I
move
was
on. It's not like that. You can shift one place to another. Usually, I used to do lap chole. The surgeon console will be on left side, but on the hernia, we shifted on the right side because the patient cart and arms will be spread in that area. So it will be little clumsy, or you can say. So we can change the position of the surgeon console. There is no fixation at a point of fixation. You cannot change the area. It's not like that. It's handy.
Yeah, thank you. And say if we are doing a TAPP for hernia, sir, how much it is going to cost more as compared to by this mantra system if we compare it to laparoscopic hernia repair?
In laparoscopy, definitely you are going to use anatomical mesh and tackers.
Yeah.
Okay. But in robotics, the tacker you can avoid. That saves down your cost of almost 35 to 40,000. So in normal laparoscopic hernia, we used to do around 1.3. That robotic costs 1.5.
So it's
not much of difference, and that gives the best part. Rather, what I feel personally, if we are a surgeon, we can place a knot, and placing a knot gives more satisfaction rather than placing a tacker.
Yeah, that's one. Yeah, thank you.
And on top of it, during the peritoneal closure, tacker can give way or fall off later, post-surgery, but suture cannot fall off. It will stay on that.
And from consumable point of view, sir, how many hernias can you do with the...
With a single instrument, set of instrument, you can do almost 10 to 12 cases.
Okay. Thank you, sir.
Yeah.
Thank you.
Thank you.
Now to felicitate Dr. Himangshu Gupta, I would request Dr. Rajanjan Kumar sir and Dr. Jayant Kumar Acharya to do the honors, please. Thank you, sir. Now, I would like to call on the second speaker of today, Dr. Arnab Kumar Saha, who has done his MCH, DNB, FMS, MN, AMS, and is the consultant pediatric surgeon of Health World Hospitals. And today his topic is Small Patients, a Big Vision, expanding the scope of pediatric surgery through minimal access surgery.
Good afternoon, everyone. So I think there are a lot of talks and mind-blowing sessions has gone in last 4 days. So I will not take much time. So I joined Health World Hospital in last 1 year after I came back from Delhi. And I want to show actually in pediatrics, the minimal access is very less still prevailing, at least in eastern part of India. So I tried to do something so that our children here get some benefit. So I will just demonstrate few cases which I have done in last 1 year in Health World, both in Asansol and Durgapur. Thank you. First case is a stage 2 empyemothoracis of a 2-year-old male child who presented with fever and respiratory distress for 2 weeks. So this is the CT. Excuse me, why is that playing? Yeah, it's not playing. Okay, so you can see clearly the left side is full of pus, and this is the pre-op X-ray which you see, the complete whiteout of the left side, and this is a post-op picture on day 0. Excuse me. Excuse me. Videos, I don't know. Videos kol kothay gelo? It is not coming here. The videos gulo asche na actually. There are 2-3 videos. There are videos. This video is not playing. Thank you. So this is the CT picture before OT, and so once we go in, you can see a lot of fibrin strands and loculations in the thorax, and we go into the 5th intercostal space in the mid-axillary right, followed by 2 additional portions, 3rd and 7th space. And after breaking all the loculations, this is after breaking the location, that is the diaphragm you can see, and this is the oblique fissure of the left side. The patient is in 1 lung ventilation, thanks to our anesthesia team. And this is the heart beating, and
হ্যাঁ এইখানে বন্ধ করে দিই ডান সাইডে এখন
And once we remove the one lung ventilation, you can clearly appreciate the lungs has expanded. And this is the immediate post-op picture after shifting the patient to PICU. And this is the post-op day 5, and on follow-up, this is post-op day 45 picture. And this is the scar we can give. We can avoid this ugly thoracotomy scar with a lot of musculoskeletal complications later. And this is the child. He went happily. And this is a 2-year-old, another patient of 2-year-old child who was diagnosed with a left-sided congenital diaphragmatic hernia with a sac. So that's why the child presented to us 2 years old. So we had a thoracoscopic left-sided CDH repair. This is the preoperative picture. You can see the entire bowel with the sac is in the left side, and the postoperative. This is the diaphragmatic repair is going on. I will just show a few seconds for that. This is also the position of the patient is in the left lateral, and the first optical port is in the tip of the scapula, followed by 2 ports for the working ports in the anterior axillary line and the posterior axillary line. In this case, we have not removed the sac. Actually, nowadays, the studies have showed that you cannot remove the sac, the outcomes doesn't matter. And when there is a sac, it's better because you have a guard so that you don't injure the abdominal viscera when you are taking the bites.
ठीक है अच्छा
This is the final picture of the repair.
शुरू থেকে चलो आस्ते आस्ते ऊपर दिखे जाओ सुइचार করে
You can see the lower lobe of the lung, which is in one lung ventilation, and child was discharged on post-op day 5. Now this is a lap assisted excision of a ileal mesenteric cyst with primary ileoalveolar anastomosis, and the child was discharged on POD 4. The anastomosis was done with 40 PDS intracorporeally, and to retrieve the specimen I have extended that umbilical incision, and the child was discharged on post-op day 4. Now come to, I saw a squeeze on the intussusception today. So this is a 9-month-old child with a ileocolic intussusception, the typical red currant jelly presented to us. And this is the intra-op picture. You can see the ileum was inside the ascending colon. So after removing, and what I have pointed in the last slide is the lymph node, which is the lead point in case of idiopathic intussusceptions. And the child was actually discharged on post-op day 2. And this is the lowest age I have operated here after coming back. He is a 1-month-old baby weighing only 3 kilos, but recurrent vomiting for IHPS. And this is the neonatal lab and the Ramstead pyloromyotomy. You can appreciate the mucosa is popping out. And this is the complicated appendicitis. The child was very sick. The counts was 35,000 with a gangrenous appendix, CRP of 300. And this is the, so I prefer to put not prefer to put a loop. I take a suture, and you can very well see the pus is dripping. And this patient came to me from Bakura actually. He had undergone a open appendicectomy 6 months back in Bakura Medical College, followed by he developed band obstructions. And luckily, we got to help him with that laparoscopy. You can see the entry point of the optical trocar is in through the varus point. This is the cranial side and this is the cortical side, and you can see the below umbilical, infraumbilical transverse incision. So the child also went uncomplicated post-op day 3. This child a female child came to us with a left ovarian torsion. Initially, I thought I will do a ovarian preserving. There is no tumors, which is very common. Teratomas are very common in this age group. The tumor markers are normal, so ultimately we have to end up in oophorectomy, and the child was discharged on post-op day 2. This is also a non-palpable undescended testis present in the near the deep ring in a 2-year-old child, which we had a single stage laparoscopy orchidopexy. We brought the testes apart from, unlike from Fowler-Stephens, we did a single laparoscopic mobilization of testicular vessels, and you can appreciate this is a modified Hesselbeck triangles in laparoscopy. We have taken that cord with the peritoneal flap and the vas through the medial of the inferior epigastric vessels, which is the shortest route. And this is a bilateral inguinal herniatomy in a 4-year-old child. And this is a cystoscopic fulguration of a posterior valve in a 2-month-old male child. The child at present is in follow-up and is doing well, and at present he is in follow-up with a pediatric nephrologist. He is doing good. This is 9.8 French cystoscope of Wolf, which help us to do a cystoscopy even in a 3-kilo-old child. This is a value we can appreciate, and you can appreciate the valve leaflets which has been fulgurated with the small bursting cutting currents. This is the bladder neck. It's a grossly trabeculated bladder. And now you invert the scope to see the 12 o'clock valve leaflets. This is the valve leaflets are coming out from the 12 o'clock. You can see the valve leaflets. Yeah, I think I am over. And any questions from the audience, please? Yes, sir. Yes, sir. Yes, sir.
What was the indication of oophorectomy?
Sir, the indications of oophorectomy is the torsion with the gangrene. You can appreciate in the picture, sir. I don't know picture, where the picture's gone.
Yeah, it was looking black.
Yes, yes. I re-rotated and waited, and there is no vascularity. It's completely gangrenous.
The gangrenous.
We talked with the parents. Initially we went, we'll try to do the ovary preserve, but ultimately we talked with the parents that it's completely gangrenous. So we removed the ovary. I had to unluckily remove the ovary of that child.
Second question is
Yes,
that
sir.
for correction of congenital diaphragmatic hernia,
Yes, sir.
can abdominal approach be taken?
Sir, abdominal approach, what we are trained in MCH, open is easier for abdominal approach because...
Laparoscopy, I mean.
Sir, laparoscopy, the problem in right side or the left side, you have to pull down the spleen, and it becomes difficult to take sutures in the cranially, because it becomes a roof for you, rather than going down. So thoracoscopic is always easier to operate.
Easier to operate. Okay, thank you.
Yeah, actually I missed part of your lecture, but from the question, it is evident that because it was a black looking ovary for a young female child, oophorectomy was done. I want to comment on that because even for adults, the guideline is, especially for young female child, even if it is black, all you have to do is, usually it will be a long round ligament, so you do a
oophoropexy.
Yeah. And we have a patient, a young female who came with torsion of ovary. We did that. She became pregnant. When we delivered her child by cesarean, we looked at the ovary. So at no cost, ovary should be removed in a reproductive...
Actually, I had an intra USG, and there is no vascularity. I didn't...
No, so that's what I'm saying. Even if there is no vascularity on Doppler, if you just do a UFREX, and because usually there is a bilateral, so she might end up in another ovary also going.
yes, yes.
And it does come back because of the wonderful collaterals. So the guidelines suggest that you must not remove ovaries for
Okay,
any reproductive or young child.
Okay, ma'am. Any more questions? Thank you.
Thank you for your excellent speech. So with this, we come to the end of the whole scientific session. Thank you.
Now for felicitating Dr. Shah, I would request Dr. R. Kumar and Dr. Jayant Acharya to do the honors. Now to felicitate the chairpersons, I would request Dr. Rupa Goswami sir to be on the podium. These are for both the sessions, so 2 felicitations each. So, thank you. Sir, please stay behind. Dr. R. Kumar, sir, you are requested to stay behind, sir. Thank you, Dr. Jayant Acharya, sir. Thank you, Dr. Rupa Goswami, sir. Now, before we move on to the most awaited part of Aismoc, that is the prize distribution, there is a small award announcement. The prize for there are awards for the panelists of the debates, Dr. Kaushalendra Thakur, CMO BSP, and Dr. Uday Kumar Das, ACMO ISP. Are they present in the auditorium? Thank you, sir. Please be on the podium for being the panelists of the debates. Dr. R. Kumar, sir, will do the honors. To be the panelist award, sir. Now for the awards for the workshops that were held on the 12th. The awards are for POCUS. I would request Dr. Dadan Prasad sir, Dr. Rajiv Kumar, and myself. Very funny moment indeed, but myself, Dr. Debjani Chaudhary. And for pediatric, I would request Dr. Debjit Sen and Dr. Riju Acharya and Shoikat Mahato to be on the stage. The pediatric team is getting it for neonatal resuscitation. Shoikat, please be on stage. On behalf of Dr. Dadan Prasad, Dr. Rajiv Kumar will be collecting the award. Dr. Shoikat, please. And on behalf of Dr. Riju, Dr. Devjit Sen will be collecting the award. Requesting Dr. Rupa Goswami, sir, to be on the podium. Sir, thank you, sir. A small token of appreciation for the judges. I would request Dr. Ashish Kumar Chatterjee, Dr. N.N. Bhattacharjee, Dr. Minati Pal to be on the podium, please. A small token of appreciation for the judges who have given a wonderful decision, I should be saying, and for spending their valuable time with us. The other judge is Dr. Shobhik Roy, who is not present here, I think. So someone from the committee will be collecting the award. So Dr. D.C. Sharma was also one of the judges, but he had to leave because of his personal problems. Dr. Minati Pal, ma'am. Thank you, Dr. Rupa Goswami, sir. What are you
Collected by someone.
So we are taking a few minutes of break to arrange the prizes. So please bear with us. So we are starting on with the valedictory session. For that, I would like to call on all the HOMs to be present in the dais. I would like to call upon Dr. B.B. Karunamay, ED Medical BSL, Dr. R.R. Kumar Sir, CMOIC, DSP and ISP, Dr. Jayant Kumar Acharya, CMOIC, RSP, Dr. Vinita Singh, GMMS, Tata Steel, Dr. Vinita Divedi, CMOIC, BSP, that Bhilai, Dr. Jitendra Nath Sarangi, GMMS, RINL, Vizag. Requesting all the dignitaries to be on the stage, please. Along with them, I would request our organizing secretary, Dr. Rajiv Kumar, and the chairman of the scientific committee, Dr. Ajit Karmakar, to also be present on the stage. Requesting Dr. Rupa Goswami sir to also be present on the stage. Now for the felicitation of all the HOMs with mementos. I would request Dr. R.R. Kumar sir to do the honors. Dr. R.R. Kumar sir will felicitate Dr. B.B. Karunamay sir. Dr. Karunamay, ওদিক দিয়ে যাও, যদি যেতে পারবেন। এদিকে কেন যাচ্ছিস, ওদিক দিয়ে আয়, এখন জায়গা করে দেবো। Next for Dr. Jayant Kumar Acharya sir. Jayant Acharya. Dr. Jayant Acharya sir, please. Next, Dr. Vinita Singh, ma'am, please. Next, Dr. Vinita Divedi, ma'am, please. Next, Dr. Jitendra Sarangi, sir. Now, Dr. Rupa Goswami sir will felicitate our CMOIC sir, Dr. Rajanjan Kumar. Now, the organizing secretary, Dr. Rajiv, will deliver a small speech on the journey of Aismoc 2026.
सर अच्छे से बोलना है छोड़ Respected ED Medical, Bokaro, Dr. B.B. Karnamai sir, CMOIC, DSP and ISP, Dr. Rajanjan Kumar sir, GMMS, Tata Steel, Dr. Vinita Singh ma'am, CMOIC, Rourkela, Dr. Jayant Kumar Acharya sir, GMMS, RINL, Dr. Jitendra Nath Sarangi sir, CMOIC Vilai, Dr. Vinita Divedi madam, CMO DSP, Dr. Rupa Goswami sir, Chairman of the Scientific Committee, Dr. Ajit Karmakar sir, delegates from different steel plants, and my dear colleagues. We have come to an end of what I believe has been truly remarkable 45th Aismoc 2026. Over the last 4 days, we have witnessed an incredible exchange of knowledge with over 150 delegates. There were hands-on workshop sessions, 5 competitive scientific papers, 3 competitive posters, insight symposium, panel discussions. The cherry on the cake was debates among our respected HOMs, जिन्होंने अपने वक्त और वाक पटुता से सबकी बोलती बंद करा दी. We should never forget the session of Medi-Quiz, which is one of the most brightest attraction of any Aismoc, and our quiz masters has conducted it smartly. This conference has served a testament to the dedication of our medical community to advancing patient care as the reflection of our theme, universal coverage of health in steel sectors. None of this would have been possible without the tireless efforts of many. The first and most important, our respected DIC, ISP and DSP, Sri Surajit Misra sir, the PR department and the whole management team. Next come my beloved and most respected Rajanjan sir, whose one punchline was, "Sir, you don't believe." This line was inspirational for me and the whole working team of DSP since the initiation of our effort back on 6th May 2025, Tuesday at 6 p.m. When I have requested him that, "Sir, I want to be the organizing secretary." With a grimacing over the face, sir has politely expressed his feeling, "Rajiv, तू कर लेगा तो? ऐसा ना हो कि सब मेरे पे उंगली उठाएं कि इतने जूनियर को ऑर्गेनाइजिंग सेक्रेटरी कैसे बना दिया." Sir had made the decision, and then he nominated me as an organizing secretary. Sir आपने कहा था ना कि राजीव कॉन्फ्रेंस होबे तो? हमार जवाब अब ई बा कि रंजन सर कॉन्फ्रेंस हो गई और उहो एकदम फाटा फाटी.
Now the person who had showed the extreme dedication of Aismoc 2026 was none other than Dr. Rupa Goswami sir, the Vice Chairman of Aismoc 2026, ENT HOD and superb administrator. सर को तो अच्छे से डांटना भी नहीं आता, फिर भी हर समय मुझे चेतावनी देते रहते थे. He had done commendable job without hampering his other responsibility. बस एक बात का मलाल रह गया, सर की मैडम से नहीं मिल पाए. Coming to the scientific committee in charge, Dr. Ajit sir, respected HOM sir, and dear delegates, I am telling you that Ajit sir is my godfather. From the medical unit support to the entire duration of Aismoc, he supported me like a pillar. Thank you, Ajit sir. You are awesome. Now the three very important support for me were Joint Secretaries, Dr. Tapas Mandal, Dr. Sutanu Sarkar, and a person with immense sense of humor, dedication, and everlasting smile, Dr. Arup Das, Treasurer of the Aismoc 2026. राजीव का तंबू 3 बंबुओं पे खड़ा था. तापस की शांति, सुतानु की भ्रांति और अरूपदास की क्रांति. आप तीनों को हमारा सहर्ष धन्यवाद. Coming to the yet another personality, काम बड़े प्रदर्शन छोटे, Dr. S.S. Patil sir, in charge of the cultural committee. He was also the coordinator. He did all his tasks very smartly. Aismoc meeting में उनका एक हास्य कथन हमेशा रहता था, राजीव चाय पिलाओगे तभी मीटिंग में आएंगे. पर बिना किसी स्वार्थ के बंदे ने गजब साथ दिया. Patil sir, your entire Aismoc cultural team, including Manoj, Riju, Tapti, Khushbu, Sahai sir, were marvelous and mind-blowing. Hats off to you for giving chances of performances for the delegate also, and everyone has enjoyed the event. We have also witnessed the scintillating stage performance of Dr. Jayant Acharya sir and Dr. Mohit. I will pay my deep respect to Dr. Hirak Chaudhary sir, additional CMO, HOD dermatology, and in charge of the souvenir, for his tireless effort for publication of 250 copies of souvenir. Before the start of the conference, hats off to you, sir. You are our backstage and unsung hero. I am paying my special regards to the accommodation committee, transport committee, Dr. Pankaj sir, Dr. Malik sir, Anil sir, Arijit, Parvez, Tarak, Arg, Priyank. You guys are really wonderful in completion of your task. Waving my bow to the inauguration and venue team, dude, you all have performed a commendable job in welcoming our delegates and smooth conduct of inauguration during our chief patron Aismoc DIC sir visit to this venue. The wholehearted involvement of other teams, stage, AI, hospitality, catering, cultural committee were admirable. Hospitality in charge Dr. Dadan Prasad sir, thanks to you for arranging solely and very smartly visit to Shiv Shakti Dham temple. Later on, Vinita Dwivedi madam ने कहा कि राजीव अगर हम वहाँ नहीं जाते तो बहुत बड़ा चीज मिस करते. The food were delicious, and this was the comment for me from each delegate throughout the conference. This was very challenging, but our catering team, including Ranjit sir, Kaushik sir, Arg, Abhishek and Chiranjit, had done commendable job without an error. I want to mention the support of two non-doctor employees, Tirth and Juddhajit, who despite their busy schedule gave the immense support to this conference. paying my thanks to another lady, respected Mukta Sen Gupta, who is our chartered accountant in our conference. Thanking all sponsors, hospitals and medical companies for their generous support and faith in our vision. Last but not the least, for my event manager Ambrish and entire Cubics team. Dear Ambrish, thank you for making our Aismoc 2026 a huge success. Your dedication, creativity and attention to detail, especially with stage arrangement, workshop station, uninterrupted running of scientific session were incredible. We received so many compliments from our guests. We look forward to work with you again. Lastly, to the delegate and HUM, sir, thank you for your active participation, challenging questions, and for making this event a vibrant hub of learning. और अंत में जो भूल चूक हुई हो हमसे तो उसके लिए हम क्षमा प्रार्थी हैं. जय एस्मॉक, जय हिंद. थैंक यू.
Thank you, Dr. Rajiv. Now a few words by the chairman of the scientific committee, Dr. Ajit Karmakar, sir.
Thank you, Debjani. Respected CUMers on the dais, my senior colleagues, friends, and doctors. Love you all. I hope we are able to give you a good, exhilarating academic fest in our scientific program designed to deliver the guest lectures were designed for helping, because most of the what you call presentations which came here were from medical side or medical associated. So most of the guest lectures were also organized to at least expose us to the surgical aspect and newer development in this thing. I also tried to bring in parity in the guest lecture, whereby different areas, except for the gynecology, I missed because I requested people, but they couldn't come. Otherwise, I would like to thank our team, the scientific committee team, who has worked tirelessly to make this scientific program successful. I'll also like to thank all the Aismoc team members, all the committees who has helped us to take the Aismoc to this place. So after a long Rajiv talk, I think this much is enough to thank all of my friends who are here and made this Aismoc great. Thank you.
I would like to call upon Dr. R.R. Kumar, sir, to felicitate Dr. Rupa Goswami, sir, the Vice Chairman of the Aismoc Committee. Next, the Chairman of Scientific Committee, Dr. Ajit Karmakar, will also be felicitated. And next, the Organizing Secretary of Aismoc 2026, Dr. Rajiv Kumar. Thank you, sir. Now for the most awaited section, the prize distribution ceremony. The first category in this section is for the long papers and the TQM paper. For that, I request Dr. B.B. Karunamai, sir, to do the honors. The prizes will be announced and the awards will be given off by Dr. B.B. Karunamai, sir. First, for the long paper award,
Hello, good afternoon. So now the time is tachycardia round, I think. Is it not? So in long paper session, the third prize goes to ISCO Banpur, Dr. Jitendra Pandey. Dr. Pandey.
Can anyone collect the award on his behalf? Someone from ISCO to collect the award on his behalf? No, 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 on behalf, he's collecting it on his. So as said by the famous poet Shakespeare, it's comedy of errors.
Now the second prize for long paper. BSL, Dr. Dipti Pravahekka. Dr. Dipti, BSL. Now the time for first prize. Priyanka Sahu, DSP.
Dr. Priyank Sahu, please. This prize is sponsored by Bhilai. This is a DC Sen Gold Medal. Now for the TQM paper. Sir, please take TQM paper award.
So the total quality management paper, the third prize goes to Dr. Bullu Sharma, DSP. Second prize, ISCO Banpur, Dr. Soumik Ranjan Sahu. So now comes for first prize. I think किसी को घुसने मत दो तो प्राइज मिलेगा. That is RFID. So BSL, Dr. Tripti Chandra.
The special sponsors are Tata Steel, thank you, sir. For the next category, I would like to call on Dr. R.R. Kumar, sir, to do the honors. The first category is short PG paper.
Third prize go to Shama Parveen. From BSL Bokaro. Second prize go to Sumit Mukherjee, DSP. Last but not least, Shikha Sarup, Tata Steel.
This prize is also sponsored by DSP. A special cup from DSP. Sir, please stay there. The next category is for the PG posters. Dr. R. Kumar sir will do the honors.
PG poster, third prize go to Nilesh Chandra, Bhilai. PG poster, second prize goes to Sisir Kumar Tata, still. PG poster, first prize go to Tarak Nath Mohanty, DSP.
A special prize for this category sponsored by ISP Banpur. Thank you, sir. Next, I would request Dr. Vinita Singh to give away the awards. The first category is for the MBBS papers. Ma'am, the mic.
MBBS paper, third prize goes to Dr. Akash Kant, BSL. Second prize goes to Dr. Pragya Jyoti from RSP. And the first prize goes to Dr. Pooja Sail from BSP.
The special trophy in this category is sponsored by Tata Steel. Ma'am, please stay there. The next category is MBBS poster.
The third prize for MBBS poster goes to Dr. Anshika, DSP. The second prize goes to Dr. S. Dheeraj, BSP, Bhilai. And the first prize goes to Dr. Rajarishi Das, RSP.
The special prize in this category is sponsored by Bhilai. Thank you, ma'am. Next, I would request Dr. Vinita Divedi, ma'am, to do the honors. The first category is DNB poster.
This was my initiation at the HOM's meet that since we have DNBs in our hospital, so we should give them an award for working in our hospital. So the third prize in this category goes to Dr. Neelakanta Sahu, RSP. Second prize goes to Dr. Harshita Gupta, Tata. And the first prize goes to Dr. Somika Mitrawal, DSP.
The special trophy in this category is sponsored by DSP. The next category is OHS paper.
Since we are all an industrial hospital, OHS becomes a very important place for us, and by the Industry Act, we have to have an OHS. So the doctors working there definitely should be, honored. So the third prize in this category, Dr. Amos Johnson, DSP. Second prize goes to Dr. A. Madhavi, RINL, Vizag. first prize goes to Dr. Gaurav Degoria, ISCO Burnpur.
The special trophy in this category is sponsored by RSP. Thank you, ma'am. Next, I would request Dr. Jayant Acharya, sir, to do the honors. He will be giving away the award for the best lady speaker. Any guesses from the audience? Any guesses from the audience? No guesses?
कोई गेस नहीं किया?
कोई guess नहीं किया.
डॉक्टर अनीशा चौधरी टाटा.
This prize is also sponsored by Tata. A gorgeous trophy for her, sponsored by Tata Steel. Thank you, sir. Next, I would request Dr. Jitendra Sarangi, sir, to do the honors. He'll be giving away the prize for the best male speaker. No guesses from the audience? Heard her name, let's see whether it matches.
Best Male Speaker Award goes to Dr. Rajnish Kumar from Bokaro State.
The special award is also sponsored by Bokaro. Thank you, sir. Next, I would request our CMO, sir, Dr. Rupak Goswami, to give away the awards for MediQuiz. So the winner team is ISP. Contestants, Dr. Jitendra Pandey and Dr. Rohit Roy Chaudhary, please be on stage. The gold medal is sponsored by RINL, Vizag. Now for the runner-up team, Bhilai, I would request Dr. S. Dhiraj and Dr. Shaunak Ghosh, please. Dr. Shaunak Ghosh, and Dr. S. Dheeraj. Oh, gosh, no, no, no. Thank you, sir. Now I would request our respected CMO IC, sir, Dr. R.R. Kumar, to deliver his valedictory speech.
Good afternoon to all. Distinguished guests, esteemed speakers, honorable members, Aismoc, and dear colleagues. As we are concluding the 45th All India Steel Medical Officer Conference, I am filled with deep sense of gratitude and accomplishment, and it is an honor to stand here and reflect the past 4 days. Over the past 4 days, the platform has truly been a nexus of knowledge. We have shared our precious research knowledge and skills to enrich each other for the notable aim to eventually benefit our patient. For example, practical application of AI in medical sciences in form of debate. We had deep discussions on management of sepsis, rapidly emerging application of PRP, and several other areas which has enriched our knowledge. We have debated challenges of hospital administration and concluded that the patient care would be best if doctor and qualified professionals work together for this purpose, proving that the field of medical science is all about teamwork and we should involve experts from all areas of societies, not just the doctors. The interactive sessions provided invaluable insights from diverse perspectives. The keynotes addressed by Dr. Ravindranath sir was extremely enriching and inspiring. A conference of this magnitude is a team effort. My deepest gratitude to organizing committee, scientific committee, session chairs. Thank you for curating such high quality contents. A special thanks to our sponsors and academic partners, guest speakers whose support added to the success of this conference. To the participants and presenters, your engagement, your questions, active participations were livelihood of this event. Participation itself is a victory, and each one, in my opinion, is a winner. But awards are only yardsticks to bring some challenges. Let me tell that it was extremely difficult to decide the awards as all presenters were of very good level. Finally, to the behind the scene staffs, technicians, volunteers who ensured their smooth running of all technical sessions, as we live today, let us carry the spirit of collaboration beyond this hall. The medical landscape is evolving rapidly, and our fight against the diseases always require us to bridge the gaps between the research, policy, and the patient care. Let this not be the end of our dialogue, but beginning of new partnership and research efforts. I wish everyone a safe journey back to their respective homes. I look forward in seeing the innovations we discussed implemented in clinics and hospitals in our hospitals. Thank you once again for making this conference a resounding success. Long live our shared commitment to the patient care. Thank you.
Next, I request Dr. B.B. Karunamai to share a few words.
A very good afternoon, my respected head of medicals of different steel plants, Durgapur, Bhilai, Raulkela, ISCO Banpur, RINL, and GM of TMH, Vinita Madam. My respected all seniors present here, the organizing Vice Chairman and Chairman of the Aismoc 2026, Organizing Secretary, and all the committees and my distinguished participants who made this 2.5 days event a very colorful, a very busy schedule from morning to evening. The Aismoc 2026 really was conceptualized few months back in a very nice way. The day of inception, we came here to this hall, the venue, to see where it is going to happen. The managements, the audiovisual arrangements, the hospitalities, it really was marvelous and commendable. The communications, the coordinations with each of the steel plant, time to time, was very communicative and easy. The hospitality we received for last 2.5 days, really, it was marvelous in terms of stay, accommodation, the conveyance, and the food. I cannot express the food, the tastes. हम पहले ही बता देते हैं कि हम अगले साल ऑर्गेनाइज करने जा रहे हैं, लेकिन इतना टेस्टी खाना नहीं खिला पाएंगे शायद. सो दिस इज माय प्रायर कमिटमेंट कि हम इतना टेस्टी नहीं खिला पाएंगे. द कल्चरल इवेंट्स यस्टरडे, it was self-driven. इतना एनर्जी एंड पर्टिकुलरली दिस दुर्गापुर पीपल्स का जो कल्चरल एक्टिविटीज़ है, जो एक्यूमेन है, लास्टली हमारा जो मैडम गाने के लिए आई थी उनको टाइम नहीं मिला, हम लोगों को बंद करना पड़ा. हकीकत यही था लगता है. कल मैडम 2 ही 3 गाना गा पाई, उसके पहले ही लोगों ने कैप्चर कर चुका था उस स्टेज को. सो द केयर टू ईच ऑफ अस who have come from distant was too good. So and the participants did their best, and during this prize distribution, it can be visualized that the 2 days competition was probably head to neck, neck to neck. So we enjoyed these 2.5 days, sir. This is my sincere thanks and congratulations to the whole team of Durgapur Steel Hospital who made this event a gala success, and to the leader and organizing chairman, Dr. Raj Ranjan sir. So congratulations, sir, to your whole team. With this, I invite you all for next year's Aismoc 2027 as we have planned in Bokaro General Hospital, BSL, Bokaro. So I expect this gathering and we try to extend our best possible scientific milieu with other hospitalities, but for the taste of the food, I cannot assure. Thank you.
Next, Dr. Jayant Kumar Acharya, sir, CMO ICRSP.
Respected dignitaries, on the dais, off the dais, सर ने सारा मेरा दिल का बात बता दिया. एक्चुअली कोई भी कॉन्फ्रेंस में याद रखने वाला चीज़ 2-3 चीज़ें होता है. एक तो साइंटिफिक कंटेंट. साइंटिफिक कंटेंट में 2 दिन में हम लोग अलग अलग फील्ड से हैं, लेकिन पता चला कि 6 महीना में ऐसा भी मेडिसिन आ रहा है, एंटी हाइपरटेंसिव, जस्ट गिव ए इंजेक्शन शॉट एट विच विल वर्क फॉर 6 months. So, and then we have seen what wonderful things have come up in robotic surgery. So, in this short period, we are able to see a vast tray of subjects, which is very beneficial. So, we are going back with full content of what the best could have been done. Second is food, as he said, gajab. तो स्पेशली फिश का जो टेस्ट और वो सब तो लाइफ टाइम था. एंड थर्ड, द कल्चरल इवेंट्स, राजीव चिल्ला चिल्ला के उसका गला भी बैठ गया है. अभी पता चल रहा है कि कितना एफर्ट लगा होगा उसको. सब कुछ सक्सेस. येस्टरडे ऑल्सो इट वॉज सो मेटिकुलसली प्लान्ड एंड द पीपल हु आर देयर ऑन स्टेज वर मैनेजिंग द शो so nicely. So hats off to you. And this Durgapur is full of talent, because so much talent it is there. I could really sense it yesterday itself. So again, I congratulate the whole team collective, and I will be meeting again in, sir, your place, Bokaro, next year with same vibe, energy level. Thank you.
Next, Dr. Vinita Singh, ma'am, GM MS Tata Steel.
HUMs on stage, dear audience. It's been a wonderful 2.5, nearly 3 days event here. I would like to take a few names. So Dr. Kumar, CMO and IC, Chairman Scientific Committee, Dr. Goswami, Vice Chairman. Congratulations for leading a wonderful team and making all this possible, because the leadership role is key in such conferences. Dr. Karmakar, I would really like to congratulate you for putting such a wonderful array of, scientific topics and making the academic feast so very, very fruitful. And there was actually so much to learn from your specialities and even others. So thank you for doing an incredible job there. Last but not the least, Dr. Rajiv, ever smiling face, and they say jack of all trades and master of all. You are blessed with so many talents. We enjoyed all aspects, and you've always been so wonderful. And the entire Durgapur team who made all this possible. Thank you very much. And last, Dr. Karunamai, they can provide catering service from Durgapur. So your food will have to be good next year also. Thank you all.
Next, Dr. Vinita Divedi, ma'am, CMO IC Bhilai.
Good afternoon, everyone. Respected HOMs on the dais, my colleagues, and my seniors, I am at a loss of words for the way it has been arranged. Aismoc 45, 2026 at Durgapur. When I came for the HOM's meet last year, I could sense the energy in Rajiv, Dr. Rajiv, so high that I expected it to be a blockbuster because he was so enthusiastic about how to conduct it. And Dr. Karmakar was, so particular about what topics to be taken, how he will do. He had planned it, I think, in his mind beforehand that this is how we have to conduct the scientific sessions, and the topics he had already discussed with all of us, what we are interested in, and he had done his homework and he had displayed it so beautifully. In the end, I would like to say, food of course is, as always, last time also I had appreciated it, and this time also, मिठाई तो बहुत ज़बरदस्त है, वैसा स्वाद नहीं मिलता हमारे यहाँ, लेकिन खाना भी बहुत बढ़िया है. I would like to thank the chairperson in charge, Dr. Rajiv Ranjan sir, and Dr. Ajay Karmakar sir, scientific chairperson, and Dr. Rupak Goswami. I met him last time also, and before that also. And they're all so enthusiastic crowd, and they make you feel a part of the scenario so well, and they take care of you. They ask you, how do you feel? I think that is the personal touch that has been given at every level. It is amazing. I think we should try to do that. Let it not be only professional. We are one steel community, and we should all have that personal touch which Durgapur has done. Thank you so much, everyone.
Next, Dr. Jitendra Sarangi sir, GMMS RINL.
Respected heads of medicals of different steel units, Dr. Bibhuti, Dr. R.R. Kumar sir, Madam Divedi, Jayant, Madam Vinita madam from Tata, Dr. Rupak, and Dr. Karmakar and Dr. Rajiv, and the delegates and seniors there in the hall. A very good afternoon to all of you. At the outset, I congratulate all the winners of the competitions that were held in the last 2 days, and they have been chosen by the the valuations, the people who had come from outside and have assessed them. And must congratulate Dr. Kumar and his team and Team Durgapur for showing up a very nice, conference. The success of a conference depend upon, as we have seen, on the scientific session, and specifically this is the unique type of a conference where we have various type of presentations, and mostly it is increased, or the effect of it is increased by the presentation by the participants. So unless otherwise the participants come and participate, probably the conference would not have that much of value. Just coming and sitting and listening to some of the talks you don't get associated with that many a times. But when there is a personal touch or involvement, and you go and present it yourself and see the various types of work that is being conducted all over the different plants, it also infuses some amount of enthusiasm in you to go back and do and work more. And regarding what Dr. Jayant has said, that we got to learn, in fact, the 5 new or 6 new antihypertensive drugs that the nephrologist has come and spoken here were the first ones which I heard for the first time. Probably those are not there into the market right now, but yes, we should also be equipped, or we should keep pace with the advancement in the science. And as we have seen, the robotic surgery is how it has taken up and started almost in tier 2 cities in all over the country, and it's going to improve the patient care. So again, I congratulate on behalf of the total collective of RINL, the effort that has been put up by Dr. Kumar and his team for organizing such conferences. And thank you all.
Thank you to all the HOMs. And now finally we conclude the session by vote of thanks to be delivered by Dr. Rupa Goswami, CMO DSP.
Good afternoon, thank you. We are already late, so I'll put it very simple and short. Respected head of the institutions on the dais, honorable guests, esteemed delegates, all faculty members. As we come to the conclusion of this enriching medical program, it's my honor as a part of a vice chairman, organizing chairman, to propose the vote of thanks. At the outset, I express my deep gratitude to all the heads of the medical services for their leadership, constant guidance, and unwavering support throughout the conference. I extend my sincere thanks to all the esteemed guest speakers for sharing their knowledge, experience, and valuable insights which have greatly enriched our academic event. My heartfelt appreciation goes to all the delegates and the participants for your active involvement, thoughtful decisions, and commitment to advancing medical science and patient care. I place on record my sincere thanks to my organizing team for their dedication, for their teamwork, tireless efforts in ensuring smooth conduct of the program. I also acknowledge with gratitude the invaluable contribution of the Public Relations Department, whose coordination and commitment played a vital role in success of this event. Finally, I extend my heartfelt thanks to all those who worked quietly behind the scenes, be it administrative staff, technical teams, support personnel, whose effort made this program truly successful. I thank all our esteemed judges for being with us on all the 2.5 days and sparing your valuable time. I apologize for any unintentional errors. With deep gratitude and sense of fulfillment, I conclude the vote of thanks, confident that the knowledge gained here will translate into better service for humanity. Thanks all. Thank you.
ए भाई हम लोग काटिएगा मत।
जो बोला था वही करना। पीछे वाइट के कारण ना थोड़ा फेसेस डार्क हो जाता है। अच्छा वो बोल वापसी का
वापसी हम लोग मैं चले जाऊंगा नहीं सर गाड़ी भी उसकी गाड़ी मेरा सामान नहीं उसकी गाड़ी में डाल दिया शाम का डिनर यहीं पे किया जाए रास्ता में वहाँ जाने के बाद अरे रास्ते में क्या करोगे लंच तो अभी 6 बजे तक पहुँच जाओगे 7 बजे तक घर जाने के बाद नहीं दूसरा दिन करेंगे रास्ते में लंच करके जाओगे
Arshita, come here. You come here first. हाँ छोड़ दे तब आ जाइए। आ जाइए अब आ जाइए भाई, अब आइए ना। एक हम लोग के कैमरे से भी ले लेंगे। हम लोग कैमरे से ले लेंगे। एक मिनट एक कैमरा से ले लीजिए Everybody in? Okay, sir. Thank you very much. Thank you. अच्छा फोटो भेजे आप लोग देखिए फोटो देखिए